Okay, I think we're live. Good afternoon and welcome everyone to this webinar on the practical applications of systems approaches in clinical biomedical engineering. Today's webinar has been kindly hosted by the Institute of Mechanical Engineers Biomedical Engineering Division. I'm John Hoskin, I'll be your chair for today, and I'll be joined by my co-chairs Nana Odom and Emma Pratt. Thank you again for joining us today. We've got an exciting program ahead for you. The webinar will be split into two separate sections. The initial half of the session features 3 talks by our key speakers who will be giving you a comprehensive overview of systems thinking and systems engineering tools and principles, each coming from a different background, so they'll be given different perspectives on how systems thinking and engineering can be used in practice for delivering effective and efficient services. We'll then move on to the second half of the webinar, which will follow up the sort of grounding in systems engineering with a series of different case studies demonstrating practical examples of how systems approaches have been used in clinical biomedical engineering services. We do encourage active participation at any time, so feel free to post any questions or discussion topics you have in the chat at any time during the presentations. My co-chairs Emma and Nana will be monitoring the chat box as we go along, and then at the end of each session, we'll be posting the questions to the presenters. Just a reminder, the webinar is being recorded should you want to watch it back or share it with colleagues. So we do encourage you to share it with as many people as possible afterwards. So first up is Tara Thornton. As a dynamic systems thinking practitioner at Doctor, she's navigated an unconventional journey to her current role with a unique academic background in music and business from the University of Liverpool, where she spent a year in China fueling her drive to redefine systems thinking in healthcare. Currently pursuing a postgraduate diploma and level 7 apprenticeship in systems thinking, Tara has tackled a number of wicked problems within the NHS, MOD, and fire services, among others, during her time at Cranfield University. Her unique background has put her in good stead when starting the NHS Graduate Management Scheme back in 2020. Now at Doctor, Tara drives NHS service improvements through digital innovation, using her skills in agile delivery, analytics, and systems thinking. So Tara's talk today will be focusing on the power of systems thinking and hopefully giving us an application in healthcare. So without further ado, I will pass over to Tara to begin the presentations.
Hi everyone, thanks so much for having me today. Really excited to be kind of sharing a bit of what I've learned over the last 3 years studying systems thinking at Cranfield. I'm really sorry in advance, I'm not very well, so if my voice goes at any point or I'm coughing, I do apologise. I'm just going to share my screen. I'm hoping everyone can see. I don't know if anyone can just sort of confirm.
Yeah, that's fine, Tara. Thanks.
Great, thank you. Okay, so I'm going to be giving you all a bit of an introduction to systems thinking. Some of you may already know or have like sort of a lot of knowledge in this area, so it might be just a bit of a refresher for you. But I'm hoping that everyone will have something that they can take away from my session today. So I'm hoping that by the end of my presentation that you'll have a really good understanding of what systems thinking actually is, how it differentiates itself to systems engineering, and how systems thinking can be potentially applied to healthcare, some key elements of systems thinking, a few methods, and one that I'm hoping you might be able to go and try and take away with your teams in the workplace. So what is systems thinking? I really like this really quite simple definition. Systems thinking is the analysis of how parts of a whole interact and influence with each other in a complex system. Okay, but what does that really mean? I'm going to take you back to a little tale that comes from the ancient East about a group of blindfolded men, and they've encountered an elephant for the first time. They're super eager to explore, and they reach out and touch different parts of the massive creature. One person feels the trunk and describes the elephant as a snake. Another explores the ear and likens it to a giant rug. And each man touching different areas of the elephant have a unique perspective based on just one part of that elephant. Now I want you to think of this elephant as a complex system, and the blindfolded men as people tackling various aspects of it. Each blind man, while having an assessment of the part that he has touched, has actually quite an incomplete and narrow understanding of the entire elephant. So I think this scenario quite nicely mirrors the essence of what systems thinking is all about. So it's kind of like taking off that blindfold and seeing how all of those different elements work together. It's not just understanding, it's about understanding the whole picture and not just its parts. So I recently went to Thailand, and they have a lot of these signs that say same but different. It's a bit of a phrase that goes around. I don't know if anyone's ever been. But we sort of hear systems thinking and systems engineering cross paths quite a lot, and you might have heard it come up in conversation. But what really is the difference, and how can we differentiate between the two? So while systems engineering is all about the sort of nuts and bolts, I believe that systems thinking is looking at the bigger picture as a whole and understanding how it all connects. So it's not just about sort of your IKEA build, your requirements, your designs. It's about seeing the entire system as a dynamic and interconnected web. And in my opinion, it all comes down to people. And that's my team at Dr. Doctor there. So systems are created and operated and used by people. So whether it's an organizational system, a tech system, a social system, human behavior, decision-making, and interaction are all at the core of all of those systems. So understanding that human element, people's motivations, their biases, perceptions, their values, is really crucial for effective systems thinking. So picture it this way. Systems engineering is your go-to for building those IKEA units, building those solid technical solutions step by step. But systems thinking is a bit like your backstage pass that lets you see beyond that technical jargon. It brings an interdisciplinary element to systems engineering might not, looking at socioeconomics and having a real focus on relationships and feedback loops and long-term consequences of problems and their solutions. I think sometimes systems thinking can sound like a load of waffle and a lot of extra work. And trust me, after spending the last 3 years studying it and trying to apply it in healthcare, I can totally agree with it, particularly within the constraints of capacity within healthcare and all the stuff that we're trying to get done on a daily basis. So why do we bother with it? Well, I believe, particularly with this people element, really gives us a deeper understanding of problems, making our solutions not just robust, but adaptable and sustainable and really fit for purpose, which I think is critical, particularly in the context of healthcare. So I thought it'd be helpful to give you a bit of a brief history of systems thinking and some of the sort of methods that have sort of been brought in over the years. And you'd have probably, as engineers, may have seen them, and clinicians, you may have seen some of these in your sort of studies and workplaces as well. So taking it back to sort of pre-20th century, there was the introduction of holism, so a concept that was rooted in ancient philosophies and Eastern thoughts, just like that sort of story that I started with. And this really emphasizes seeing whole systems, and it's very much a precursor of modern systems thinking that we see today. And we also see in this sort of period, biology and ecology really beginning to focus on relationships and interactions within ecosystems, which really set the stage for systems thinking that we see today. Then we have lovely Ludwig over here with his cigarette. For some reason, every person that I looked up for researching all of this today, nearly everyone had a cigarette. So there we go. Anyway, Ludwig, a scientist from Austria, he had some really interesting insights. So he saw that whether you're looking at living things or machines or entire organizations, they all have certain patterns and structures in common. So based on this, he came up with general systems theory, which you probably all have heard of. But what is it? So it's a way of thinking that says all complex things, which we might call systems, have similar parts and ways of behaving. It's like finding a universal language or a set of rules to help understand and connect all sorts of different systems, no matter what they are. So this idea was a bit of a game changer because it gave us a toolkit to really look at complicated stuff and break it down into those smaller parts that are easier to manage. So it was really helpful for big complex projects like designing airplanes and rockets, where people needed every different part to work together perfectly. So that's what system engineering is all about, right? Making sure that all of those parts of big projects fit together and work smoothly. So that's sort of where the influence of general systems theory has on systems engineering as well. So it doesn't just focus on that one piece of the puzzle. Engineers are looking at how all those pieces fit and work together. And I like to compare this as like sort of being a conductor of an orchestra and making sure that every instrument is in tune and playing in harmony. So this way of thinking can help engineers create more efficient, reliable, and easier to use systems. So really, this sort of influence has been a huge help to make some of the most complicated projects so successful. So we've actually now got Norbert, and we've upgraded from cigarettes here. He's come in with the cigars, and I just love these photos. I think they're brilliant. So he was a mathematician, and he introduced the concept of cybernetics. So we can think of cybernetics as the science of steering and controlling things. So it's all about understanding how different systems like robots, computers, or even societies control themselves and communicate. And in this period, we also had Claude Shannon, which some of you probably would have heard of as well. And he came up with the information theory, which is basically the study of how messages and information zip around within systems. And his work was really important because it laid the foundation for the way we all share and receive information today. So like how your emails and texts fly across the internet. And some people go as far as to say he invented the future, but I'll let you decide that. In this period, we also had Stafford Beer with his fantastic beard, who developed the viable systems model, which applies systems thinking to organizational structures. So this is where my knowledge comes in a bit more, and this is one of the sort of main models that we studied at Cranfield. And as you can see in the VSM model on screen, it essentially draws out an organization system by system. So it starts by looking at the meta system, which is almost like the brains of the operation, responsible for coordination, control, intelligence, and policy. And then you have the operations, which is sort of the day-to-day activities and what directly interacts with the environment. And then everything on the outside of the environment, everything on the outside is the environment. So that's, the market, the industry, society, nature, any external factors within that system that system has to respond to and survive within. So the environment can be quite complex and changing, and particularly within healthcare. And the system needs to be able to adapt to remain viable. So there's a couple of use cases for VSM. So we can use it both as a framework to show a functioning organization and how they remain viable. Or we can also use it as a tool to aid diagnosis of threats to viability, and also a way to design new organizational structures as well. The integration of VSM in healthcare has helped structure a more adaptable and responsive healthcare organization across the NHS, and it's been used since the early 2000s. And more recently, one of my classmates, Andrew Singfield at NHSE, has really been pushing this method in the sort of the top end of NHSE, which is quite exciting to see. This is sort of an example of a completed one, but I'll send that through with this presentation afterwards. Excuse me. So now we have systems dynamics. So Jay Forrester at MIT introduced the concept of system dynamics. And this is what focuses behavior on sort of complex systems over time, using feedback loops, which is kind of like the conversations within the system, and then time delays, which are the pauses before the system reacts. So on the screen, you can see some of the examples of systems dynamics modeling. His work led to the development of tools for system stimulation and modeling. And they've been a really big help in areas like business management, where companies can use them to test out strategies, and in public policy as well, where governments can use them to hopefully make better decisions. When it comes to healthcare, especially understanding the spread of diseases and things like that, systems dynamics really shines. So it helps experts in public health create models that can predict how illness might spread or how effective a new health policy could be. So that way we can make smarter choices about how we protect people's health. So now onto one of my personal favorites, and one that I've personally found most helpful in my work as a healthcare management consultant and in project management. So developed by Peter Checkland, soft systems methodology was a response to that hard systems approach. And it very much focuses more on human-centered and interpretive approaches to understanding really complex problems, particularly within an organizational context. So it encompasses methods like rich pictures, which I'll come on to later, CAPWOs, building out root definitions, and conceptual models. So you can see a few of them on the screen here. And they sort of help really unpick those messy problems. And what I love about SSM is it's not just about finding those quick fixes. It's about digging really deep and understanding all different stakeholder perspectives and coming up with solutions that make sense to everyone involved. I think of all the methods that I'm talking about today, I think it's probably the most inclusive and thoughtful, maybe with CSH as well, which I'm going to come to in a second. But it really kind of, I think, helps make decisions stick and work well in the long run. And I've actually found it a really great way to improve communication and collaboration across teams as well, and empower all your stakeholders so that they become actively involved in your problem-solving processes. So there's also CSH, which I've just mentioned, is another method that I love and quite similar, really helps build that sort of communication and collaboration. And this uses a 12 questions framework in both the as is and the to be states of a problem to unpick and find solutions. So what CSH does is to challenge us and ask the right questions about who's involved, what their goals might be, and who gets to decide what's important. It also makes sure that everyone's voice is heard, especially those who are often left out of conversations. This approach is really handy in fields like environmental planning and social work and public policy. And by using CSH, professionals in these areas can map out that landscape of a problem, spot hidden snags, and come up with solutions that are fair and ethical and effective. Excuse me. So we also had at this time the introduction of the Vanguard method, which is probably one of the most well-known methods, created by John Seddon, who apparently doesn't smoke according to all Google images. So here he is. And he's got a great tan as well. So maybe that's a cue to not smoke. Anyway, yeah, he's probably one of the most well-known in the business world. And I think that's because the Vanguard method really focuses on the eyes of the customer and what they really want and need. So it's a bit like taking a magnifying glass to a problem, and at every step asking, is this really helpful for the customer? Vanguard has been applied to a lot of sort of healthcare service improvement, focusing on patient-centric care and operational efficiencies. For example, I've seen sort of some research in 2020 for helping improve service level outcomes in an occupational therapy service in England. So systems thinking has grown a lot over the years, and it now incorporates all sorts of theories and ideas and all the things I've just run through there, as well as newer things like complexity theory and a few others as well. So it's increasingly becoming applied across fields, and sort of public health and healthcare is increasingly using these sort of applied methods to try and attack complex problems. And there's been a real push to integrate systems thinking as well into education in recent years as well. So teaching students to really try and think in terms of that systems approach from an early age. Within healthcare, although we might not identify it as systems thinking, there is that real growing focus on more holistic, patient-centered care models informed by systems thinking, which is really exciting to see. So if you like the idea of systems thinking and you're thinking about implementing it with your team, there are some key components of systems thinking that I like to call a bit of a quick toolkit. So to start off with systems mapping, which I'm sure you've all probably seen before or used in some type of way. And there are lots of different types of systems map, but they're essentially a way to visualize and understand complexities of a system. So it involves identifying and mapping relationships and interactions within systems, providing insight for effective interventions and decisions. Systems mapping is essentially, systems mapping is really essential for clinical engineers and healthcare management because it involves charting out how, for example, medical devices and healthcare professionals and patients all interact, helping identify areas of improvement and innovation and investment to be able to enhance patient care. You'll be able to sort of have a look in more detail when I send the slides over of these maps. But there's some sort of healthcare related examples there. So the next sort of area that I like to think of in this toolkit is interconnectedness, which I think is really the essence of systems thinking. So it's all about understanding that everything in the world is interconnected, from the air we breathe to the technology we use. And this concept really shifts our perspective from that linear model of thinking to circular and more holistic, recognizing that that kind of complex web of relationships and dependencies are all part of a system. So in the NHS and healthcare, interconnectedness is vital. Every aspect from patient care to clinical equipment is part of that complex network. And understanding these connections and how they relate to each other help us see healthcare not just as a collective of independent elements, but as a cohesive, independent system. Synthesis. So this is all about combining different elements and understanding that whole. So unlike analysis, which breaks down complex systems into parts, synthesis focuses on how these parts connect and interact, providing holistic views of systems. Synthesis in healthcare involves combining diverse information from patient data to resource allocation to perform a comprehensive understanding. It moves beyond analysing individual symptoms or departments and focuses on how collectively they contribute to patient outcomes and systems efficiencies. Emergence means that when many individual things interact, they can create something complex and sometimes unexpected, like, for example, a caterpillar turning into a butterfly. It can demonstrate the unpredictable and dynamic nature of systems. For example, the NHS is moving towards integrated care systems, and this is showcasing how collaboration across different healthcare providers like GPs and primary care and secondary care, community and mental health services can all come together to integrate to improve health outcomes. But as we know, this can then create a lot of unexpected problems and complexities. And we have feedback loops, which is part of systems dynamics. And this is really essential to understanding how systems can self-regulate. So, for example, reinforcing loops amplify changes, whilst balancing loops counteract them, creating stability. And recognizing these loops when you're unpicking problems can help us understand those systemic behaviors and their impacts. Feedback loops are really crucial in sort of patient care and system management as well, because they involve understanding how patient outcomes influence clinical practices and policy decisions, ensuring continuous improvement of quality of care. And causality, which is the final one I'm going to touch on here, in systems thinking goes beyond that simple cause and effect. Sorry, excuse me. Causality, yes. So it goes beyond simple cause and effect. It involves understanding the dynamic interplay of actions and reactions within systems, which can lead to deep understandings of how changes of one part can affect the whole. And causality in healthcare is really, really complex. So it's understanding all these things that you can see on the screen here. So education, income, neighbourhoods, all these different factors and how they might interplay to affect health outcomes. And grasping these cause and effects relationships is going to be really key for the future of our healthcare, for effective prevention, treatment, and promotional strategies for health. So I think I've kind of touched on this here in sort of the rest of the presentation, but I thought it'd be good to go into a bit more detail of why we want to use systems thinking in healthcare, or why I think we should be using systems thinking in healthcare. Healthcare is inherently becoming more and more complex, involving so many different interrelated components. Systems thinking can help understand these complexities holistically, which we've seen with more focus on patient-centric care, population health management, and personalised care. And this holistic element to healthcare is crucial for improving patient outcomes and systems efficiencies, as we as people and as patients become increasingly more complex. There's some graphs there that relate to my next slide. So let's take a really high-level example of the rise of patients with multiple morbidities. You don't want to say that after a few drinks, do you? Multiple morbidities, so those that have more than one healthcare condition. So over 15 million people have long-term conditions in England, and the increase in those of multiple morbidities is only rising year on year, as you can see on screen with those stats there. So now let's take a step back and look at systems thinking, look at this from sort of a systems thinking lens and a more holistic picture. So if you're living in one of England's more deprived areas, you're likely to experience multiple morbidity 10 to 15 years earlier than someone in a more affluent area. And there are stats after stats after stats that are frankly quite scary relating to this topic. And the implication on the NHS, patients with long-term conditions are behind 50% of all GP appointments, 64% of outpatient appointments, and more than 70% of in-bed day beds. inpatient day beds. And they're also the reason that every 7 in 10 pounds is spent on health and social care. But here's the real kicker. Despite the enormity of the issue, our healthcare system often misses the mark. And this is because systems tend to focus on individual diseases or patient issues. And this results in complex and uncoordinated care pathways, leaving patients confused and often untreated, and clinicians frustrated. People with multiple morbidities commonly experience reduced mobility, chronic pain, shrinking social networks, and much lower mental well-being. And while there are resources out there to support all of those different problems, currently, if we look at the way our health and social care system is working, it's super fragmented and messy and uncoordinated. And that's just one area of healthcare. Take health tech, for example, the industry I'm currently working in. One of the biggest challenges we have is interoperability with different digital systems across the NHS. Even trying to send something on SharePoint from one trust to another is near impossible. And there's just so many digital systems that it's making it really, really hard to tackle these sort of problems. So there's hundreds and hundreds of different problems within healthcare, right? Then how do we find solutions with all these challenges that are so complex? Well, I think that systems thinking could help. And if any of you have had a chance to read my article on the Future NHS site, you may have remembered that I described systems thinking as seeing the forest for the trees. And by that I mean, if we focus on one specific problem without considering its context, we will create solutions that only offer temporary relief, like treating a symptom instead of addressing the underlying cause. So if as a healthcare practitioner, clinician, engineer, project managers, whatever field you might be working in, if you start to apply a systems thinking mindset to the problems that you're facing at work, we can collectively move towards a more patient-centered, holistic approach to care, whereby the root cause of problems is analysed, rather than chucking a plaster over the top of issues and hoping that it will stick. However, from my experience over my apprenticeship, I've seen firsthand how hard it can be to apply systems thinking in the workplace. It takes time that no one has, and it can often feel like going down a rabbit hole and opening a can of worms. I've also found quite significant resistance to change and trying new ways of thinking. And I also believe that really we need specialised training in this area of thinking, particularly if you're looking at whole systems and entire companies. I believe that there are some really important areas to focus on, so active stakeholder engagement, a culture of continuous learning, and adaptability to change will be really critical if you're thinking about trying to apply systems thinking in your workplace. So I thought, after talking a lot, there might be something that you might be able to take away from today. So part of soft systems methodology is an exercise or a method or a tool that we can call a rich picture. And you might have heard of this before. So a rich picture is a systems thinking tool that's used for understanding complex situations, usually sort of at the advent of the problem in the beginning. And it's essentially drawing. It's drawing or trying to clear out diagrams that visually represent various elements and relationships within a system. So you could start this at your place of work or of any projects that you're working on. You can write a problem statement at the beginning and have a go at drawing out the problem and thinking about all the different relationships that are at play. And you can do this on paper, or like more recently, I tried it on a Miro board that worked really, really well. So I guess you can kind of imagine not just capturing the physical components of a problem, but also the human and the emotional and the social aspects. So imagine you're looking at a complicated scenario like a business organization or a community project. A rich picture can help you see all those different parts that are involved, the people, the processes, the problems, the interactions, in one overview. So it's a bit like drawing a map of a big city, but instead of just drawing the roads and the buildings, you're also showing the traffic flow, the busy areas, the quiet zones, where people might gather and interact. And the beauty of a rich picture is that it's really flexible. It doesn't require any specific format or symbols. You can use drawings or cartoons or any kind of visual representations you can copy from Google Images, like the one you can see on here. So it's a bit like doodling, but with a real sense of purpose. You're trying to capture the essence of a system, the mood, the conflicts, the connections, and the challenges. So I hope that you might be able to give this a go, and let me know if you do, because I'd love to see some of the outcomes of this. So the next time you're tackling a complex problem, I hope that you might try and channel your inner systems thinking detective and consider the entire elephant, and you might just uncover some surprising insights. Thank you.
Oh, fantastic, Clara. Thank you very much for that. Really interesting perspective on systems thinking. I think definitely touched on some challenges and issues that our attendees would definitely be familiar with working in the NHS, particularly to do with time. I think that's really hits home for a lot of people in here that they would love to improve services with systems thinking and system engineering, but having the time to step away from service delivery, for instance, and really work on that is really where they get unstuck. I suppose I'd put a question to you that for people working in these chaotic services where they've developed over a number of years with little inefficiencies and processes and systems, and they're so interdependent on other services working well as well. Would you have any advice on sort of what models to start with, or how to make sort of little impacts in terms of systems thinking?
Yeah, absolutely. Sorry, my voice is going now. Good job that I got through the presentation first. Yeah, absolutely. I mean, I think it might be a personal preference, but actually I've seen it working really effectively. But any sort of soft systems methodology, because it's got that more human-centered approach to the way of thinking, it actually pulls in stakeholders and gives people a chance to voice their opinions in a kind of different way. So, example, using those rich pictures is kind of putting people almost borderline in an uncomfortable position of something they're not used to doing, and something, it's not just I don't know, running through an agenda and everyone talking about their key items and blah, blah, blah. It's putting someone out of their comfort zone. And actually, a lot of the time that brings new ideas and fresh insight and gives people sort of almost like a common ground. It doesn't matter what level of work you're working at, brings people together in a situation where it gives opportunity for every voice to be heard. So I would say giving something like that a go could be really helpful for engaging stakeholders, particularly within the NHS.
Fantastic, brilliant. Would you have any kind of links or software or websites you think could help with this? You mentioned the rich pitches. Is there examples online anywhere that would be helpful?
Absolutely, yeah. I can send a list through. Give me a couple of minutes and I can pop some into the chat.
That's fine. I think we have had one question come through. As I say, if anyone has any questions, we'll give you a minute or so to pop them into the chat. So question for you, Tara. We've struggled to engage stakeholders in the NHS, usual issues with time. If we could convey that ultimately it would be more efficient, with better outcomes, may get better engagement. Do you have any ideas or tips from your experience that could help?
It's a hard one because it's, I think, probably the biggest thing that I've struggled with in my journey with systems thinking so far. What I would say is, if you're going to be looking at trying to apply systems thinking methods with teams, it would be trying to have like a little preamble sort of intro call, rather than sort of chucking in a 3-hour workshop and hoping that people turn up. Having like a sort of a bit of a 20-minute or a 15-minute introduction to systems thinking, and giving that kind of, this is why this is going to work, and this is, we're not just going to put a plaster on the problem, we're going to really look in the depths and find solutions that are going to be more sustainable. And I think it's showing and identifying the stakeholders that you're engaging with, and looking at sort of the problems that they're facing, and then saying, look, here's how we can actually build a real solution that's going to work, not just a knee-jerk reaction. So I think it's, focusing on engaging with the stakeholders and bringing them back to the basics, and giving a bit of a preamble before you jump straight into a big method or a big workshop.
Great. And I suppose this is probably one for the NHS services. One of our main stakeholders, effectively our patients. So it was really good for you to touch on patient-centered care earlier, but how would you recommend engaging with those stakeholders as our patients?
I think those that do engage, so we've got at Doctor, we work with some sort of patient liaison groups and things like that. And I think that those that volunteer to engage are actually usually very keen to do things like this and workshop and stuff like that. I guess when you're looking at the wider audiences, it might be a little bit more challenging. But again, I guess echoing what I said before, it's taking it back to basics and actually listening and understanding the different stakeholder perspectives to then be able to build something that works for everyone and for the patients.
Fantastic. Brilliant. I don't think we've had any other questions come through just yet. So yeah, but thank you very much for your time, Tara. As I say, it's incredibly interesting. I'd recommend everyone to go and have a look at your blog post on the NHS Futures platform if people haven't signed up for it already as well.
There's some really great comments as well, some really interesting conversation on there. So yeah, I definitely recommend having a look.
Brilliant. Thank you very much.
Thanks, everyone.
Okay, so definitely an interesting perspective on systems thinking from Tara there. Without further ado, we'll move on to our second speaker. So next up on our agenda is Tanya Galliara. Tanya is currently the Associate Director at Network Rail Consulting. Graduating University College London in 2004 with a Master's in Mechanical Engineering, she's a Chartered Engineer and Fellow with the Institute of Mechanical Engineers, holding Certified Systems Engineering Practitioner certification with the International Council on Systems Engineering, or INCOSE. With experience across rail, nuclear and defence sectors, she's evolved from a mechanical engineer to a systems engineer. Her career spans small to large enterprises and has seen both the adoption of systems engineering practices and the transition from conventional approaches through to model-based systems engineering. She's contributed to a number of key projects, which you've probably heard of, such as technical governance at EDF Energy and HS2, Crossrail stage gate transition, product updates at AWE, and the introduction of model-based systems engineering at the UK Atomic Energy Agency and rail projects in Australia. Tanya's held various management roles, including systems integrator roles for Trans-Pennine Route Upgrade and East West Rail, introducing new ways of working, both on business processes and engaging the workshop. Today, she'll be talking about applying a systems engineering approach in organizations. So we've got a little bit of a different perspective to Tara. So without further ado, I'll pass across to you, Tanya, if you want to share your presentation.
Thank you very much, and a good afternoon, everyone. Right, let me get this going. Wonderful. So just a quick check, can everyone see that?
Yeah, that's coming through okay, Tanya. Thanks.
Wonderful, thank you very much. Well, good afternoon. Thank you so much for your wonderful introduction there, really appreciated. My background, I have an affiliation with the IMechE through numerous years, but working in a different sector primarily. So my main association has been with the railway division. And as John was alluding to there, I've worked on a range of different projects. And I'm actually going to be bringing up some case studies from that experience in the course of this presentation today. When I first started out working in the sort of systems engineering field, it was still very much the conventional, traditional approach to systems engineering, which was very document heavy, very focused on individual projects and individual delivery. And over the course of my career, particularly with the introduction of model-based systems engineering, or MBSE, it's become a lot more of a dynamic approach. And there'll be a couple of threads and themes that I'll be picking up in the course of my presentation today that you'll see there are linkages with what Tara was saying earlier in her presentation, that hopefully you can see there's a resonance there in some of the things that can support the NHS and other medical fields in what your aspirations are, what you'd like to do. Really, the key message that I hope you take away from my presentation today is that in applying a systems engineering, a systems thinking approach to organizations, it's about helping to focus not just on the individual detailed elements that might be delivered or specific projects. There's also the opportunity and the ability to think a bit more holistically, think bigger picture, and think actually, where do we want the wonderful organisation that is the NHS to be going? Can the organisation work better at that organisational level, as well as in situations relating to individual projects? For me, part of my past experience around that is, yes, we can do that. And the key things to focus on in terms of the systems engineering, systems thinking approach is to think about the teamwork, partnerships, and collaboration that you want to achieve. And actually, how do you articulate the information that you need to support those things to happen? So just to sort of really summarize and to sort of reiterate what I'm saying is I'm really talking around the approach which is known as enterprise systems engineering. And I've just highlighted here a couple of references. So you can sort of see that this has been sort of it's not a new thing in the sort of systems engineering, systems thinking space. It's some of the papers go back to 2015. These papers are freely available online, but also I'm happy to share the slides afterwards if you wanted a bit more information. What I will probably say is that one of the things that we sometimes don't do very well in the systems engineering space is think about the language that we use when we're trying to adopt the approach and bring the approach into the teams and organizations that we're working with. But really, there's nothing different in enterprise systems engineering to the sort of traditional, more conventional systems engineering that you may be familiar with from your sort of day-to-day experience. And we'll touch upon some of those points a little bit later on. It's really elevating the perspective that you're looking at from the immediate problem that you're trying to solve to thinking how the principles can be applied to the organization at an industry that you're working with actually as well. A lot of the elements are very similar to what we used to with regular sort of systems engineering approaches. So the sort of four key elements that probably really stand out in terms of the four areas around enterprise systems engineering are the development round through adaptation. So the example that often gets called up in that as an example is the mobile phone. So this is giving away my age a little bit, but I can remember the sort of more conventional rotary landline phones. And obviously, you know, I'm sure all of us have seen how phone technology has developed from, you know, through to landline, through to mobile, and so on. But even with mobile technology, how at one point it was the popular, the fashionable thing with mobile phones was to have something that was really small, that was portable, that could be easily put in your hand or in your pocket. And now the mobile phones that are out there at the moment, some of them are, you know, almost the size of tablets. But the point there really is around how the technology has developed through staged adaptation. It's not gone from one thing to another thing overnight. There's been an evolutionary process, and that's probably a very key thing to remember in trying to apply this approach to an organization, is that we're not going to be able to change organizations overnight, just like we don't change projects and the way of working overnight. We have to be able to think about the appropriate adaptations that can be put in place and setting it as part of a wider life cycle for the organization as a whole that fits where that organization wants to go. Supporting that, hopefully most of you are getting familiar with the fact that we often have to do quite a bit of planning in delivering any piece of work that we're doing. And probably a key point with enterprise systems engineering is around making sure that the approach is part of the strategic thinking that happens at a senior leadership level. It's something to make sure that not just the people who are doing the work on a day-to-day basis, but the leadership team are also brought into the direction, the way of travel for this as well, making sure that everyone's on the same page in terms of going in the direction, because that can make or break a successful delivery and a successful evolution of the approach in an organisation as well. That goes hand in hand with governance approaches, and actually enterprise systems engineering really does help support a wider picture. So things like our mission statement for an organisation, assessing what needs, what support we need, assessing what kind of technology is appropriate that we, in terms of what we want to adopt. Things like budget plans, human resources, all the sort of wider picture things that support a successful delivery. One way that a colleague put it to me was that I was talking about an organisation as if it was a project rather than just purely an organisation. It's what do I need to make that successful project happen? What do I need to make that successful organisation happen? And with a sort of systems thinking approach, we are thinking holistically, bigger picture, all the bits that contribute to that, the success of that organisation. And of course, underpinning that alongside with the conventional processes that we might follow, for example, requirements management, so on and so forth. Enterprise systems engineering also has some additional processes that support it as well. Particularly for me, the one that I really resonate with in what I've put here around understanding the capabilities, both in terms of what we wanted to articulate in terms of the capabilities of the organisation, but also enterprise architecture. And the reason why enterprise architecture resonates with me in particular is because of my model-based systems engineering background. Because for me, that's a very useful way of communicating with the stakeholders, to pick up on something that Tara was saying about sort of rich picture images and essentially remove it. For me, it's an approach that's helped remove language barriers, particularly when you're working in an organization that has a management layer and a sort of highly skilled technical barrier team. Sometimes language can be a hindrance in trying to communicate why we need something, why we need to do something, how we take things forward. So for me, MBSE is very much an extension to what Tara was saying around the rich picture side of things. And when I talk about one of the case studies, I'll be able to give a couple more examples of what I mean around that as well. But just before I sort of dive into that, just a little bit of a reminder around the sort of traditional systems engineering approach and the sort of more conventional approach. So most of you maybe sort of resonate or sort of recognize some of these within the sort of day-to-day work that you're doing. So sometimes there's an external party that comes in to outlay the foundations for the systems engineering approach. Now, I said language is important. I'll be very careful here when I talk about external. So what I mean here by external, it doesn't have to be someone that's from outside the organization, but it's someone, maybe yourself as a systems engineer, coming in to work with a specific team. And you may have seen from your own experiences that you are seen as the outsider. You're coming into an existing team to support them with a systems engineering approach. But that team, because it's not an approach that they've used before, not something that they're familiar with, there is that sort of antagonism that happens, that you're seen as sort of that external party trying to change something that's perfectly fine, or a particular approach that they've done for a period of time. And that's quite actually a similarity with thinking about it at an organizational level as well. If you've got some entrenched views and attitudes that this is the way we've always done it, sometimes when you're trying to introduce either the conventional or the enterprise sort of systems engineering approach, you might get some of that pushback that you're coming in and trying to change something that's perfectly fine in their view. Also, generally, when we're following a more conventional systems engineering approach, we're usually coming in and focused on a very small system in the scheme of things. It's coming in and looking at a very specific aspect of a project. We're focused on bringing in a new IT system, for example, to pick on a NHS project that's happened a couple of times before. New IT system to support the organisation, or we're bringing in sort of robotic surgery techniques, for example. It's a closed loop system in a very specific instance, and that can help because it makes it more manageable to deal with from a systems engineering approach. But again, what you can miss from that is actually the more holistic perspective. They're sort of looking at it from the top down side of things. So why would a particular IT system help? Why would having robotic surgery help in a certain situation? Well, actually, I'm not quoting anyone here, so I apologize, but just as an example, robotic surgery, you might have the argument that it's saving money because you can get through more patients, or you can have there's a better recovery time for patients. Equally, you could come up with the perspective of, oh, but you're trying to get rid of staff, for example. So with a conventional approach, you can sometimes miss the nuances that come with integration and bringing in a new product or a new system. But by elevating it and thinking about it from an organizational perspective, hopefully you're able to capture the nuances and able to enable a better introduction of a way forward, because you're fitting it into the why the organization is there. Also, with the more sort of traditional approach, operation of a particular product or system is treated separately to the development of that product or system. So again, to sort of think about the robotic surgery equipment, for example, and again, I'm not trying to sort of quote here, so I apologize. I'm not trying to sort of say that this is the way things work in the NHS. But an example that I've seen from the nuclear industry for a similar sort of thing has been that the robotic technology has been developed independently by an academic organization. It's been brought in to be deployed as part of a wider project, a specific instance, and there is this separation between the development of the product, getting it tested, getting ready for installation, getting it ready for use, and actually deploying it. And then sometimes there can be some problems that have arisen where actually when you're actually deploying the technology, things crop up that the designers hadn't anticipated because they work in a different environment. They don't have that feedback loop from people who actually use the systems. As I say, that's just from a nuclear project that I worked on, and so I'm extrapolating to the health system. But I anticipate that there might be, similar instances where technology has been introduced, but because there's been that disconnect between development, bringing in a new technology versus actual deployment, it's how do we capture that feedback loop to make sure that any improvements are included, but also that if we repeat the project in future, that we're avoiding the same mistakes as well. And that can be one of the downsides of taking a more conventional closed loop approach from a systems engineering perspective. And really, for me, my observation is that the reason why that happens is because you're not including the people who are actually actively using that system as part of the regular conversation. And when I talk about sort of machines, it's machines in the sense of process 1, process 2, process 3. We tick the boxes, we've achieved all the processes, therefore it must work. But we don't have that because we're not involving people in the conversation. We're missing that feedback element to it. Before I go on to the case studies, what I wanted to really to share here was around sort of similarities and differences, and actually key differentials around the enterprise systems engineering approach, thinking about an organizational element to systems engineering. So a lot of the processes will be quite familiar to you in terms of similarities. So things like requirements management, being able to define and articulate interfaces, the verification and validation that happens, stakeholder management, and being able to generate the evidence for the work that you're delivering. These are common processes that you are familiar with that happen in your sort of day-to-day role as systems engineers. They apply to sort of the smaller projects, but they also apply at a organizational level as well. It's just that because the picture has expanded, the amount of information that you're trying to capture, the amount of data that you're handling from an evidence gathering point of view is so much more. And for me, that's why I quite favour the MBSE approach to doing it, because for me, that's a better way of both articulating the information, but also capturing the evidence. I think trying to apply a sort of more traditional approach, for example, putting everything in a requirements management database, having Word documents, for example, when you're trying to think about it holistically at an organization level, that volume of data just gets too much to manage and can cause you to miss key priorities and things. So that's something to bear in mind. And I'm not saying that model-based systems engineering has to be used for every single project that you want to do, but it's just something to be mindful of if taking a more conventional approach at an organizational level is better for you. It's thinking about how you capture and how you approach the amount of data and the amount of information that you're handling. In terms of specific differences, one of the things that I keep coming back to from my past experience is that when we're talking about the sort of small systems that we're used to dealing with on a day-to-day basis, it's very easy to fall into using technical language, because the stakeholders that we're working with all will probably be familiar with the language and be using that on the day-to-day basis. It means the same thing to them. But when you are looking at different levels within an organization, management layers generally will be using a different language to the technical elements of an organization, and there can be a lot of crossed wires when you're trying to talk between the two teams, and that is something to be very, very mindful of when applying the principles at an enterprise or an organization level. Audience, I differentiate audience as well, because there's a difference in the audience between internal to the organization, but there's also external audiences as well. So, for example, government related or regulatory related audiences tend to be external to the organization, but they are not the same as the management level of an organization. So you again have to think about the type of language, the type of priorities that's important to that audience, as well as to those that are internal to the organization as well. Another aspect that I found really important to articulate is ownership and responsibility. So one of the projects that I'm going to share with you in a little bit, one of the conflicts that I came across there was around, it basically boiled down to this confusion or around language, because stakeholder for that person meant something very different to what it meant to me as a stakeholder. And so there became this little bit of a fight, I would say, around ownership and responsibility. Who is responsible for managing stakeholders? In that particular example, part of the reason or the conflict around ownership and responsibility came down to the silos. So who's looking after the technical aspects? Who's looking after the program management? Time delivery? Who's looking after the commercial relationships and cost of delivering a particular project? And at an organizational level, sort of the business level, these become really important. It's how do you knit together these different elements? So the interface question becomes, how do you bring the business together as a whole? And naturally, as you delve down and go down to the detail of something that you're trying to do, naturally it becomes interface between box 1 and box 2. But at an organizational level, it's, how do you bring together your doctors and your nursing team, as an example. How do you bring together your management team, looking after bed allocation with priorities in terms of the different types of operations that a hospital needs to deliver? How do you sort of manage incoming blood tests coming from a GP surgery versus blood tests that are taking place at a hospital? So it's lifting up the outlook in terms of the types of interfaces that you're considering at that organisational layer. Also, life cycle can play quite a big impact as well. So at an organisational level, the life cycle generally will be quite longer in terms of timescale. It doesn't have to be, but it can be. And you may find that you have to break down life cycles so that you have an overarching life cycle for what you want to achieve as a whole. Within that, as you borrow down and get the depth of the individual things that need to happen, each individual project will then have a life cycle of its own. So you have that sort of grouping of V cycles, or however you define your life cycle to think about. And that juggling that together can be quite a difficult job. And therefore having that, making sure that you've got the right stakeholders in the conversation becomes very important as well. Making sure that you've got the program manager involved in your conversations as well is important. So just as an example to support that, when I was working at AWE, we were looking at a product upgrade, and we always included the program manager as part of the conversation, because there were so many different technical teams contributing to the delivery of that program. But additionally, we also had to include external parties as part of that conversation, because the product that we were doing was part of a bigger system. The rest of the system was being delivered by an external third party. And the role of the program manager becomes really important in making sure that we've identified and brought in all the stakeholders, but also fitting in with the life cycles that are identified and working with as well. So in the context of that example, there was the life cycle of the program that was being delivered, which had multiple individual life cycles sat within that. The external thing that we were delivering to also had its own life cycle. We had to make sure that we were getting some synergy between the life cycles, but it also led to conversations around prioritizing requirements and prioritizing work that took place as a result of the bringing those two programs together. And I guess the last point I wanted to raise there was around the radar. So hopefully most of you are familiar, but risks, assumptions, issues, dependencies, and opportunities. The reason I mention that is, as in that difference is that when you're working on a closed system project, that gets very focused and can be very closed in terms of the nature of the project that you're working on. When you're thinking holistically at an organizational level, that can be quite a big database of information to manage. But I also want to really emphasize about the opportunities aspect of it as well, because that's, for me, that's an element that I've noticed can get forgotten about alongside those other elements as well. So for me, part of thinking about this at an organizational level is about trying to take some positive conversations at it, all of the opportunities that we hope to deliver as a result of taking this approach in the organization. So how does that all sort of tie together? So I think for me, really, if from an organizational point of view, the key thing is that we're usually responding to a business case, or as part of why are we doing this work, and we then have to demonstrate how we're delivering that business case in a successful way. In order to do that, we need to encourage collaborative relationships and conversations, making sure that all the stakeholders have been identified and feel that they're involved in the conversation. To me, in the examples that I've seen, that's generally led to quite a positive change to the organizational dynamics and relationships, both internally within the organization and externally as well. Apologies, I'm just keeping an eye on the time to make sure I don't run over too much. So I'm just going to go into my case studies. So the first one I wanted to bring up was UK Atomic Energy Authority. So for those of you that may have heard it before, it's an academic organisation, or primarily academic-based organisation, that's responsible for the R&D into the nuclear fusion technology, and thinking about how we can both develop it, but then make it into a viable alternative source for electricity generation in the country. When I joined the organisation, it was primarily very academic focused. They were doing lots of projects within the UK, but also had many international collaborations and partnerships as well, particularly with Europe, but also some with the US as well. And they were very much at the start of their systems engineering journey. They were taking some very conventional approaches. They had very good processes in place already for requirements management and other things like that. But where they were struggling was in identifying and managing the interfaces and their life cycle, particularly because they weren't necessarily responsible for all aspects of a project. They were giving funding to work on the areas that they were very competent at, but in the scope of delivering a wider project, they would have to have collaborations with international partner organisations. So they would not necessarily be developing a complete nuclear fusion reactor on their own. They would very much rely on those international partnerships. That in turn was interesting because whilst there wasn't necessarily any particular, I guess, difficulties around sharing technical information, what was interesting was some of the more political or the soft conversations. There was protectionism that was happening them between different organisations. You had to jump through a lot of hoops to get information about what another organisation was working on or what another project was working on in order to be able to bring it together for something specific. So that really was hindering a lot of the communication and innovation that could have happened. And so when I joined, I was supporting the introduction of model-based systems engineering, and I'm not going to read out everything on there, but essentially really the first key thing that it really helped with was removal of that language barrier, because we're working with international partners. Although English was the main language that was being used, when you're asking people where English isn't necessarily their first language to try and articulate requirements or to respond to, verification and validation information, nuances were being missed. And also, by taking that model-based systems engineering approach, what it helped with doing was removing the perspective of focusing on the political aspect and helping to focus on what are we trying to achieve by developing this particular technology. As a result of that, it helped with articulation of the interfaces, and therefore not just the technical interfaces, but actually what organisations, so sort of more commercial barriers, what organisations need to be involved, what are the timescales that so it helped bring the focus around to the who, the what, the why, the when of delivering a successful overall program, and just enabled us to also bring in the commercial and program stakeholders. So particularly where the funding was done on an annual basis by governments, it helped articulate and justify why funding bodies should provide funding at certain points of time, rather than demurring to their interpretation of the work in terms of how it's being presented. Overall, the sort of positive takeaway was just the improved stakeholder management, and the fact that the in particular the non-technical stakeholders, were a lot more engaged in the conversation around supporting projects. And one of the ways that we kind of verified the approach was to start off with small projects and then scale that up to larger projects. So that helped prove the approach as a whole. Now, this particular case study, although the focus was on a better overall technical product that was being delivered. By bringing in the MBSC approach to it, what it helped with was actually thinking about the program and the stakeholders from a holistic point of view. So although that wasn't the original intention to think about how it would work better collectively as an organization, by helping to break down some of those barriers, it helped improve the speed and the responsiveness of both UKAEA and its international partners to developing ideas. So where UKAEA is at the moment, currently, they've actually established, I think, a new R&D base. I think it's I can't remember where it is now, my apologies. I think it's in Rotherham, I think, where they've got this new body in place to help fast track some of the technologies and the R&Ds that's taking place, to really pick up the speed on introducing fusion technology into the UK. Next example I wanted to bring on was actually my role prior to Network Rail Consulting, which was this with East West Rail Company. So as I mentioned before, most of my experience was with the railway industry. The railway industry generally is very comfortable with systems engineering as an approach, but they very much followed a conventional, traditional approach. It's very data heavy, document heavy. And my particular interest or the role that I was brought in to support was around integration and interface management. East West Rail was set up as an arm's length body to the Department for Transport. So what that meant was that we weren't involved in the day-to-day detail of delivering the railway. What we were trying to do was act as or support Department for Transport as the informed client, but we would be having some more technical conversations, in order to ensure a successful delivery. And for me, really, the first issue there from day one was around the language barrier, because Department for Transport, being a sort of government body, it was difficult to go to a conversation with them because they were not interested in technical detail. But a lot of the people that were employed at East West Rail were technically biased in terms of they were engineers. They were that way orientated in terms of their specialism. So I prepared a strategy which talked about the introduction of model-based systems engineering, but it broke it down into two sections. One was to have system architectures for the technical detail, but to have an enterprise layer. And it was the enterprise layer in particular that I was focusing on with my strategy there, because it was to support the evolving nature of East West Rail as a company as the program developed. So initially, we were supporting primarily the technical delivery, but the intention was that the organization would support and turn into an operational organization. And so this was the key point here, that we were going to be turning from a deliverer of the railway into the operator of the railway. That meant that as well as the technical output, there was going to be significant organizational change happening, which meant that it would mean restructuring the organization. It would mean having to identify what capabilities that were needed. How do we recruit for those capabilities? How do we bring on board the right kind of partners to support the evolution of the organization into an operator? Over and above that, there'd be various other industry-related integration that needs to happen. So needing to work with Network Rail as the infrastructure provider, needing to work with rolling stock train operators for operational services, needing to work with British Transport Police for security, those kind of conversations, working with utilities companies, thinking about the role of EWR, not just as a railway, but how to support door-to-door journeys. So having to engage with taxi companies, bus services, local authorities to help customers, as in passengers, with the day-to-day journey. We're not just going to be a railway just stuck there that people have trouble getting to. How do we help passengers go from their starting point to their end point effectively as well? So there are many conversations that were not just due to sort of the particular technical aspect that had to be encompassed. And so really with the approach I was taking there was two key areas that I was really, well, 3 areas, but the 2 key areas that I was focused on was the organizational change element, but also that engagement with the external stakeholders, the people that weren't involved in the day-to-day delivery of the technical railway. And so that really led to this sort of focus on the enterprise systems engineering approach for East West Railway. Right. And I promise them this is my last slide. So how do I think that evolves or supports the NHS? I think for me, what I see the NHS as an enterprise, as a holistic enterprise. And I think for me, the reason, the important reason for taking this approach for the NHS is to make sure that we have all the relevant parties involved in a conversation about how the NHS moves forward, goes forward. There's so many different elements, in terms of what medical teams provide, in terms of what hospital teams provide, in terms of what the management teams provide, but it's getting, enabling these different stakeholders to communicate with each other and be able to articulate and manage those interfaces effectively in order to bring together to work effectively as one unit, as one holistic unit going towards one common vision. And for me, that's where the benefit really of taking an enterprise approach would really be beneficial for the medical environment. So yeah, thank you very much.
Fantastic. Thank you, Tanya. That was great. So we'll just give it a couple of minutes for some questions to come through. Yeah, it's certainly a wealth of systems engineering knowledge there. That's brilliantly different perspective to the first talk we had anyway. I'd certainly be interested to know if anyone attending has used a model-based systems engineering approach within their services. That would be quite interesting to know. We've had a couple questions to do with language barriers. So do you have any advice on how to capture the more nuanced learning points from projects, e.g. verbal and feelings?
Sure, absolutely. So something that's worked well for me in when I've tried to develop this has been to sort of do this over the course of several workshops, but also taking the outputs of those workshops and then playing it back to the people that have attended, getting them to actually confirm or verify that the information is being captured correctly. And that's, for me, that's been quite useful because it helps create this sort of dialogue and engagement when people can see that you are proactively trying to listen to what they're saying.
Yeah, definitely. I think in terms of our stakeholders within clinical services anyway, that's language is definitely important, and showing that you actually know what they're talking about as well. Second question, again, I've got to do with language barriers. Language barriers often happen in the NHS due to our overactive use of acronyms. So they're everywhere in the NHS. Any advice on how to deal with this?
Okay, yeah, I can empathise that with them because the railway industry is also full of acronyms as well. So one of the ways that I've got around this is to try and move across to functionality. And actually the RTFs that Tara mentioned as well. So we particularly, and this is something that I found particularly useful about the MBSE approach, is it's the ability to create these sort of functional perspectives, layers of pictures, which sort of take away the use of acronyms. So with East West Rail, one of the things we did was to create sort of user journeys through, how, for example, how would a patient, how does a patient engage with the medical system from first seeing a GP through to having the problem dealt with from a patient perspective? What should that look like? Creating that as an RTF type of journey. So that's one way that's worked well for me.
Great, fantastic. Yeah, I think it's definitely that patient element. As you've thrown acronyms at patients, they're not going to have a clue what they mean. So that's definitely a good approach to take. Okay, I think that's probably all the questions for now, Tanya. I think you're staying along for a little bit anyway, aren't you? In case anyone.
That's right, yeah.
questions later. But thank you again for that presentation. That was brilliant.
No, thank you.
Okay, so moving on again. Our final key speaker is Dr. Helen Mees. So with over 20 years in the electromechanical engineering industry and a PhD from Loughborough University, Helen's early career was in the defence industry, including roles at both Babcock International and GE Naval. She joined the Institute of Mechanical Engineers as a policy manager in 2013, first as head of engineering and society, and then as head of healthcare policy. As a chartered engineer, she's currently the host of IMechE's engineering podcast, Impulse to Innovation, as well as being the vice chair of its biomedical engineering division and also a past trustee. She's also a member of the Royal Academy of the Royal Academy of Engineering's Healthcare Policy Topic Group and a Health Foundation Q Community member. In 2018, Helen founded her own company, the Care Machine Limited, which aims to provide innovative technology solutions, business management and training to medtech startups, small to medium-sized enterprises and researchers. Passionate about technology and healthcare, Helen's worked with several high-profile clients, including the NHS, where she was responsible for recruiting over 1,000 engineers at the start of the COVID outbreak to support clinical engineering services at the Nightingale hospitals. She continues to develop thought leadership across the medtech sector, championing the importance of biomedical, pharmaceutical, and mechanical engineering in medicine, with appearances on TV and radio, as well as writing numerous reports and articles on health tech-related matters. So today, Helen's going to be sharing her insights on the Engineering Better Care Toolkit and how we can apply that a systems approach to problem solving. So over to you, Helen. Thank you very much.
Jonathan, thank you for that fantastic introduction. It always sounds weird when people kind of read out my background. I'm going to plow straight into this presentation. So if you give me a second, I'm going to turn off my camera and put on my presentation and I'll take you through it. Hopefully you can all see that. And
yeah, all good.
Excellent. Thank you, Jonathan. Well, as I say, thank you very much for the invite to speak today. And my presentation, I'm going to focus on talking about the Engineering Better Care Toolkit, how it came into being, why systems thinking lends itself particularly to healthcare, and how the toolkit is structured. I do have a few examples of how it's been implemented, and I'll probably leave those to the Q&A section. So we'll focus on this for now. But so let's begin with a little bit of back history as to how the toolkit was developed and why. You've heard already from our two wonderful speakers about the application of systems engineering and systems thinking, and particularly the theories behind it. What I'm hoping to show you today is how that has led to the development of this particular toolkit and how it's been used. And it all started back in 2016, 2017, when the Royal Academy of Engineering commissioned a report entitled Engineering Better Care, a Systems Approach to Health and Care Design and Continuous Improvement, which was undertaken by Professor John Clarkson, who was and still is head of the Engineering Design Centre at the University of Cambridge. It was co-produced with engineers, clinicians, and healthcare leaders from the Royal College of Physicians, the Royal College of Anaesthetists, the Academy of Medical Sciences, the Health Foundation, and the University of Cambridge to explore how engineering systems approaches could be applied in health and social care to develop systems that meet the needs of patients, the NHS staff, and particularly carers, who we often forget about in these situations. The framework developed in the report focused on the very early stages of design and improvement, where decisions are being made regarding the scope, the aims, and the key themes of an improvement process. So we're very much focusing on quality improvement, and you'll hear me talk about improvement quite a lot throughout this presentation. So comparing current health and care improvement processes with engineering systems approaches, the report found that there was certainly a lot of potential for health and care improvement to benefit from the rigors that an engineering approach might bring to them. And with particular respect to systems being centered on people, and that was something that Tara talked about right at the start, their needs, the capabilities, and their role in understanding, designing, delivering, and maintaining a successful outcome. Targeted iterations to maximize the chance of success prior to implementation of an outcome. A stable improvement methodology that seeks not only to explore the real need, but also evaluate a range of possible solutions in order to select the best option for that healthcare problem, and the identification of possible opportunities for and threats to a system before they arise, ensuring that the delivery of that task is robust and adaptable. Something that Tanya pointed out about making sure that what we're actually going to deliver is going to be successful, and that people are going to stick with it. All health and care improvement initiatives involve people, processes, technologies, the physical environment which that system is in, and the system itself. And that in turn gives us the structure of the system as a whole. So the report set out to look at what that structure was based on a series of questions related to people, systems, design, risk, and management perspectives. So the idea was that if we take each of those 4 perspectives, we can look at them as individual components within an overall improvement process, but they are also uniquely, inextricably linked, if you like, to the each other and to the challenge in itself. And so we need to make sure that we can integrate all of them to be useful, versatile, and to produce a systematic process that's repeatably able to be delivered over not just a short term, but the long term part of this issue that we're trying to address. So the report and the idea and the thinking behind the report was really to focus on these particular perspectives, and that approach really was intended to accommodate both design, where you might want to develop something new, a new program perhaps within a hospital service, or create continuous improvement where there is a desire to improve an existing system. So you've got something you already know about, but you know there's weaknesses in it and you want to try and improve it. And we know from our experiences, and I'm sure Tanya and Tara would agree with me, that when you're implementing systems approaches and problem solving in this way, it's not about fixing the problem and walking away. You are continually trying to apply that process in a very iterative way to continually make improvements. And this kind of questioning approach uses a range of techniques to determine the requirements for the system. Particularly, we want to look at how the system is structured, how it's organized. We want to look at creating and evaluating what opportunities are available to us, what things that we can design or redesign into the system. We want to be able to produce quantitative analysis and predictions on how that system will behave where appropriate, and assess possible threats to and opportunities for people and other systems that might be affected by what we propose as our change. And we also want to integrate all the individual elements and deliver a system that's going to be fit for its intended purpose. So we need to make sure we know what good is going to look like in the future. And this diagram here shows the very first simplistic questioning approach that the framework adopted. And these were the kinds of questions that needed to be asked in order for us to improve our system. So how did this then turn into a toolkit that we could use in reality? Many of us, and Tara, I'm sure, with her research into systems over the years, we can go down many rabbit holes looking at the different methodologies and insight into what drives a systems approach. But ultimately, what the healthcare service needs is something that they can apply. So the first prototype of the toolkit was derived directly from the original report, and in some respects, and in kind of some form, I suppose, it continues to undergo evaluation and improvement within the improvement community and the quality community. Even now, many of the people that are using it are feeding back into the team at Cambridge to add nuanced changes to it as time goes on. And I, having seen it when it first came out, have seen just how much change has occurred over time. It's been demonstrated quite thoroughly to function across all scales in the healthcare system, from service level improvements right through to organizational, cross-organizational, and even cross-sector level change. And it's very capable and very flexible at dealing with a variety of levels of complexity and performance improvement. So we know that its application is very robust. And I think this is what makes it so interesting to me particularly. At the heart of the toolkit is an improvement model, which aims to translate the descriptions of the system and the systems approach from that was originally developed in the report into real actionable program of improvement. And the model, or the HEX as we often describe it as it is, contains 7 activity strands as how we've described them. We talked about acronyms. We try and avoid them as much as possible. But these activity strands divide the model up into a stage-based view of the improvement process. And through these activity strands, we're able to inquire into what kind of problem we're trying to solve and how we might approach it. So it's intended to be flexible, and it's also intended to inspire inquiry in order to understand the context of the challenge that we're facing, and also the gaps between the current performance of the system and what we would like it to be, the desired performance. And those strands, as you can see on the screen there, the particular aspects of those includes understanding the context, which describes the circumstances or setting that surrounds a system and all the factors that could influence it. Defining the problem, which describes the details of a particular challenge within the system, because it may be that the system we're looking at really confuses us initially because there are so many aspects to it. So we have to be very clear in defining which part of that system we're going to focus on. Developing the solutions, which describes ways of solving the problem or problems within the system. Often when we tackle new issues or existing issues, it's not just one problem that's the issue. It can be a combination of things that are causing the system to fail. And then we need to collect evidence. And this describes the information and all the measures used to evidence the validity of a particular solution. So we're not just collecting evidence that's demonstrating the problem, but also evidence and measurements that might improve the problem as well. And this enables us to make our case for change. And what are our set of arguments, if you like, in support of delivering a new solution? Often the people that we have to go to are the people with the purse strings. And within the likes of the NHS and within healthcare itself, often the people with the purse strings are the ones who are going to say yay or nay to a project going forward. So by having a strong case for change, we can influence those people who are within our stakeholder network, who we have to impress upon to give us the cash, basically. Now, we also need to manage the plan. Tanya has been very clear in her presentation about how much planning goes into the delivery of change, and this is very, very important. And we need to have a very detailed proposal to support our case for change, to enable those changes to be delivered and what the outcomes are going to be. And right in the center, we need to agree the scope. Now, the scope describes the context of the improvement that we kind of envisage. You know, what are our goals? What are our ambitions for change? But also it helps us define the boundaries of the system of interest. Now, we need to remember that this is not necessarily fixed right at the beginning. What we think we know about the system after we've approached some of these other strands may actually change our scope as we progress. And at some point we will fix that scope, of course, but it may be quite a flexible thing for some time. And so we need to be very mindful of the fact as engineers within that healthcare setting that we need to have buy-in from everyone before we fix what that scope will be. So at different stages of the process, there's going to be different targets for each of these strands. And for example, in the early stage of the project, we're likely going to be concentrating on the context and the problem itself. And later on, emphasis is going to be moving towards a solution and the evidence, for example. So it will ebb and flow throughout these different strands as you progress through analysing your particular issue. I will come to the three illustrations at the side there, which cover Six Sigma, the IHI model, and lean thinking shortly. And there's a reason that I've put them there, and I'm sure you're kind of wondering what that might be, but I am going to come to that shortly. Over time, that initial diagram that I showed you of those very basic questions has expanded into quite a significant questions map, which sits around the outside of the hex and around the outside of those strands. And this can be particularly useful at the early stages of assessing a problem, but it can also offer us insight relating to other activities at any stage of the process. And I think that Tara and Tanya will agree that asking questions throughout the process, what is it we're trying to achieve? Why are we doing this? How are we going to do it? All of these questions are fundamental to ensuring that we draw a strong conclusion and have a good, stable solution at the end of our assessment. And you'll be able to see from some of these questions that some seem very obvious, and others not so obvious, but some of them might trigger other questions. So this, again, is not a definitive list of questions, but it's an opportunity to poke at, I suppose, and pursue the direction that you want your project to go. So I'll come back to the reason why those other three little illustrations were on the screen. I want to caveat here at this point that the improvement tool is not meant as a replacement to other existing improvement and quality processes. things like the IHI model, which is being adopted across the NHS, Lean and Six Sigma, are all valid tools and methodologies. The purpose of this process is for it to be a companion or an enhancement to those existing processes. We're not trying to teach you a completely new method that you have to forget anything else that you've learned. But following John's extensive research and the work that his team did, they discovered that many of these existing tools, particularly for improvement and quality, not only overlap each other, but also some have gaps in their structure, which we hope, as we've developed and used the Engineering Better Care Toolkit, we've been able to kind of close some of those gaps. And so really this tool is seen as a support for existing methodologies. If I might give you an example of that, you may be familiar with the act, plan, do, study kind of model, and you can see, and what we've done and how the toolkit has been developed is that the improvement model overlays that act, plan, do model, and you can see from this diagram where the gaps are and where they've been filled by the Engineering Better Care Toolkit. The white spaces are where there is no overlap between the two. The lighter spaces is where there is some overlap, and the darker colours are where there is absolute agreement between those two models, and you could use either. So it gives you an opportunity to see where the weaknesses are, and then to use some of the questions or the tools within the toolkit to fill those gaps. So let's take a little closer look at the tools and the resources themselves. Well, there is actually a physical form of this toolkit. It's not just kind of, something in the ether. It is comprised of two very large folders. One is the guide, which contains the descriptions of the processes that can be applied, and the theory, if you like, behind the model itself. And the other one is the resources folder, which contains all the tools. It has cards and posters and worksheets, and a whole workshop structure that can help you through the facilitation of the process. And these are not something that you can kind of carry about. They are really for practitioners like myself to be able to understand and develop our way of training and facilitating these workshop sessions. The resources themselves, though, have kind of provide a whole way of kind of getting into the process of dealing with a problem, and most of these actually can stand alone. So they enable you to kind of pick and choose, if you like, what sort of things you might want to do. And the toolkit itself contains a pack of 8 cards that describe service users, service stakeholders. It has case studies. It has the questions, activities, and tools to kind of encourage you to analyze the problems you're trying to focus on. It's got a set of posters to illustrate the concepts and the tools for improvement, and that includes planning and all kinds of worksheets that you can fill in. And it also has a set of worksheets as well, and working documents that you can keep up to date, because as I said before, it may be that things change over time. These documents are not static, they are dynamic. And this is a dynamic process that we're talking about. So it may be that through that workshop process or workshopping over time, you end up repeating or going back to worksheets and updating them. Excuse me while I just have a drink. Now, all of these resources can be found on the Engineering Better Care website, and I've put a link to that right at the end of my presentation. And so they can be used both electronically or in hard copy form, depending on what you're trying to achieve. The systems process can, I think, be simply summarized as a linear yet iterative process. That kind of sounds about face, but it is, there is a start to finish of this process, but throughout it, you will go backwards and forwards to finesse what it is you're trying to deliver in terms of your improvement process. So it begins with a trigger question. Why are we doing this? What are we doing this for? Why are we here? That gives us a rationale for improving or an existing system or developing a new one. We then face what is the problem. And this enables us to clearly articulate a view of a better system based on our understanding of the current system. And we can then define who should be involved, who are our stakeholders, who are the people who are going to be affected by this or could affect change within it, and who's going to deliver this, who is going to commit to making this program of change happen. And then we can ask, what is good going to look like? And this gives us an understanding of the success and how it can be measured. Where do we want to be at the end of this process? And we can define what should we do next by developing and executing a clear plan of action to deliver the systems. And you can see here how the posters within the program link to the worksheets that you can use to capture all of that information. So although it goes from start to finish, you can see that we loop around on numerous occasions to capture all that information. And I should mention the report, the systems process, the toolkit, as I say, are all online. It is over about 380 pages of text. And that's not just a report, which is a good 50 odd pages, but the actual theory and thinking behind the Engineering Better Toolkit is huge. So it's a lot to get your head around and a lot to absorb. So if you would like to be trained to use the toolkit, or you would like to be facilitated to get your team together and have a day to explore a problem that you have, then as I say, myself and other colleagues within Cambridge and outside are trained to use this toolkit, and we can bring it in to help you develop your solutions. So thank you very much for listening. My presentation has been quite short, but I hope it might generate some conversation. And I do have some slides as well that might that if you want to talk about how it's been applied in different situations, I can talk you through those. But Jonathan, thank you very much for letting me present today.
Fantastic. Well, thank you very much for talking today. That was really good. As I say, I think a lot of people will be familiar with some of the existing tools you mentioned, Six Sigma and Lean and the kind of ACT, Plan, Do, but maybe not sort of how they would relate to their own services, and kind of each model would have their own deficiencies of not quite as relevant to maybe NHS services. And actually, I think what we found in our services, I think we've tried some of these before and actually found that they trying to keep the momentum and the steam going after a while. They kind of, it's that initial implementation, and then it's trying to keep that going, really.
It is. It's a difficult one to manage. You've got to have the support, not just of your team and the people who are trying to make change and trying to implement the solution, but the people who are the movers and shakers within the organization. If you don't have the buy-in of senior management, these sorts of ideas and issues are never going to have longevity. So they need to be part of this process. And I always encourage people who are looking at bringing a team together to problem solve. invite the CEO, invite the senior directors, invite the people, the finance office and the procurement team, because ultimately they're all going to have some kind of say. It's not just an isolated system, as Tara talked about at the beginning. It's systems of systems. And one change that we make is going to affect all the other systems around us. So bring those people to the table, create conversation. It's really important.
Yeah, definitely. That's definite. So we've had a question from Hassana. With the life cycle and regulations of equipment in the medical sector, how would you encourage lean and continuous improvement?
Oh, goodness me. That is a shocking question. I think it's always going to be a difficult one. I think one of the things that one needs to be able to do is be aware of what the system is outside of what you're doing within the medtech sector. There are constant changes to regulatory requirements. There are constant changes to, to the standards by which you need to work. So you do need to have a good line of sight of what those changes are and what's coming up. You need to be aware of what policy changes are going to occur through government so that you can be agile enough to pick up on those and make changes. Don't wait for those changes to occur and then you as a business be stuck trying to make change. You need to be well ahead of the game. It's important to have, for example, one of my roles at Babcock was as technical assurance engineer. And that role came about because we'd been very slow on the uptake of certain standards. And so when it came to auditing, we realized that actually we had bottlenecks within our process. And so my role was to get my head around all of those standards and be ready at the start of any project to enable the engineers to understand where those bottlenecks were and where the changes were going to come. So I think it's about preparation. And if you can be prepared, if you have someone within your team who is looking ahead to what might happen, that's going to help you to implement those systematic changes within the process that you have, and it will keep things rolling a lot easier. I hope that answers the question.
I think so, yes. Yeah, I think, well, the big one for our kind of clinical engineering services has really been the medical device regulations and that coming in, really. So definitely what you're saying about trying to get ahead of the curve and getting there in there with the policy changes at the start is definitely going to help your services in the long run.
Absolutely.
We've got a few more questions, actually. Ideally, getting a team together, but in at the start of an improvement project is preferable. But could this be used by an individual who has identified a process that could be improved?
Absolutely. I have used this on many occasions when I've had little problems to solve and not been able to get my head around what all of the issues are. So yes, it really is a tool that will enable you to not only solve your issues, things that you might have problems with on a daily basis, but bigger projects, the sorts of things that Tanya was talking about that she's worked on in rail. And what I have found is as well that it works just as well outside of healthcare. This is a toolkit that has been developed in a way that is broad enough to understand the nuances of work that engineers face on a daily basis. So I've used it in all kinds of situations. I worked with a team actually who are on a healthcare project up at Nottingham Trent University, but they were psychologists. So their language was completely different to mine, and we talked about acronyms and things like that. The things that they were saying were very different, but we were able through the toolkit to explore a whole range of things that they needed to focus on in a project, and overcame a real bottleneck to the project that they were able to then go on to address. So yes, I would say it has tools that you can use on a daily basis, but tools you can use on the long term as well.
Yeah, great. I think we did have a comment on that language perspective, which you were talking about as well. So, but from the perspective of the international standards, as native English speakers, we do have a duty of being careful of our use of English, avoiding jargon and colloquialisms, which I think is definitely a point to remember.
It is, yeah. I mean, and also the issue around ethics as well. You know, one of the things that Tara talked about was, you know, sort of risk and those kind of things, and that in itself, when we're looking at doing risk analysis on a project or a particular problem, you know, understanding the ethics of how are we going to affect change to patients, how is it going to affect the family of that patient, and not just the doctors or nurses that we might be working with directly. So being very aware of those kind of issues and incorporating them in, and that use of language, is really important for engineers today.
So we've got it. Are there any case studies on the website which demonstrate use of the tool?
Yes, there are. There are quite a number of case studies, actually. There's a couple which are very useful. One is actually on aging population and looking at an elderly patient and the kind of needs and things that she needed from social care. And there's another one on pharma, on medication as well. So there's a couple on there, but there are many more examples, and the Cambridge team are always very helpful, you know, in providing sort of examples. There's another very good one as well on patient discharge, which was a piece of research that one of the research students at Cambridge was involved in, looking at the bottlenecks within patient discharge and how that could be addressed. So again, that's a really good example, work through example of how you might apply the toolkit.
Great. I think, we'll encourage everyone to kind of go and find those case studies and have a good read through just to see how they might be able to apply it in their own services. I think your question approach that you mentioned earlier in terms of sort of supporting those other systems engineering methods, definitely a good approach to take. But what struck me was the what does good look like? And I think sometimes in terms of our clinical services, we're so far away from targets and where we think we should be that we might have forgotten actually what good looks like. And it's just, would you have any tips on really defining that scope, which you mentioned, and in terms of where there's so many problems and actually where do we focus our attention?
I think there's the process really comes about when you start to explore people's views on the issue. I did a wonderful workshop with a great clinical engineer colleague of mine down at Guy's and St Thomas's before Christmas, and they were looking at wearables and how patients might react to the use and the offer of a wearable. Excuse me. It was very much, we had a wonderful patient group who were very vocal, and it was very clear that you know what it was they wanted, what good looked like to them, that they wanted a tool that, or a device that wasn't going to break down, that if it did, they knew how to maybe put a new battery in it or things like that. They wanted to be autonomous in their life, and that really then defined what good looked like for guys, you know, and for the clinical engineering team. That they knew that they needed to make sure that the patients at the end of the day felt safe and confident that they could use the device, and that was the goal. And so that came from not just asking the question, you know, what do you want, but also within that activity of having a patient interaction session really brought that to the fore. So I hope that's a good enough example of how you address that. You need to ask those questions, and you need to create activities and opportunities to get responses to those questions. But also I should say as well that there's a wonderful phrase which John Clarkson uses, and he talks about designing for delight. And I think as engineers, we often forget that. We often think about designing for practicality or for efficiency or for sustainability, but we don't necessarily think about designing for delight. And we need to think very carefully about what sort of technology we develop or what processes we change that is going to make people happy. And I think that's an important message to get across.
And that's it. And I mean, with patient services, it's all about making good patient outcomes, or as you say, designing for delight. So I think that's definitely, when you're looking at all of the problems that you might have, picking what to choose and how to set your vision and goals, it's definitely a good place to start.
Yeah.
Brilliant. Thank you, Helen. That was really interesting. I don't
welcome.
think we've had any more questions on that one. Again, hopefully you can stick around if we did have any more later on.
I will, definitely.
So we've come to the end of the first half of the session. So hopefully we've given you a pretty good grounding of systems engineering principles and tools. And we're going to move on to the second half, which will hopefully give us some practical examples of how we actually apply some of this theory and principles in some of our services, but particularly with a sort of healthcare spin. So first up, we've got Dr. Adam Partlow. He is a senior clinical scientist who works for the Rehabilitation Engineering Unit at Cardiff and Vale University Health Board. Adam's talk will be primarily about using systems engineering in software. So if you're there, Adam, if you want to take control of the screen.
Yes, I'll do that just now, John. Thank you very much. So as John was mentioning, I work at the Rehab Engineering Unit in Cardiff and Vale University Health Board. I'm a clinical scientist that specializes in clinical scientific computing, which generally means that I have a foot in clinical service delivery, and I also have my other foot in the quality improvement and development of software for service improvement, which now and then may be software as medical device, but that's a talk for another day, I think. So what I'm going to be talking about today really is using that systems engineering in software. Tara, Helen, and Tanya have all mentioned systems engineering and some of the tools and techniques we can use, but how can we apply that in a practical application such as the development of software? But first of all, why do I use it, I guess, is the question here. First of all, I could say, forgive me, I'm going to be using some software engineering terminology rather than that systems engineering terminology, but they are, can I say, interchangeable? But they are well defined, I'll say that way. And I've got some references later on if you are particularly interested in the definition of some of the terms that I am using. So really, for me, why do I use systems engineering and software? The main one being that it helps me break down a problem into its component parts, making it a lot more manageable, a lot more manageable technically, a lot more manageable from a safety or risk management perspective, and more manageable from a time management perspective, because obviously that's something that we don't have much of. I wish I could have more, but I'm not going to get any more. So being able to break down those problems into bite-sized chunks is really beneficial to me in an area where I've got really limited time. This is a text-heavy slide, but I don't expect you to read any of it. It's just some terms which I may use today. But really, the purpose of this slide is just to highlight that software is not just about the application or the piece of software that you're developing. As you can see there, we've got business requirements specification, software requirements specification, stakeholder requirements, and system requirements, which really highlights that there are things outside the software which are extremely important to consider. How do you design software so that it works well within existing processes? How do you design software so that it meets the business requirements of the organization? How do you design software so that it meets the stakeholder requirements, and so on? There's a couple of references at the bottom of that slide to international standards, which I found very useful over the years. One, for being consistent with my language and terminology or vocabulary, and two, now and then to refer back to them as pointers for something that I don't do, for some of the processes that I may not do very often. One other thing to keep note is, again, something that Tanya mentioned earlier, is that you don't do this every time for every project, but it's very useful to do as regularly as you can, I've found, for software. So what's the case study that I've got today? So my case study is on one of the functions that we perform during clinical gait analysis, and that's a clinical examination. As you can see in this picture here, we've got a clinician doing a clinical examination on our mascot, Di the Dragon. And this perspective is from the scribe's perspective. And you can see they've got a sheet of paper on a clipboard where they're writing down a lot of the clinical measurements that the clinician is dictating to them. And if we look at this piece of paper in a little bit more detail, we can see there's a few issues here. So the scribe has possibly made some mistakes and also run out of room to do a few things. At the top of the page, you can see the scribe is crossed out left and right because on this particular clinical examination form, it's using the medical left and right. So left is on the right and right is on the left. So when you're writing things down, sometimes you need to think before you fill in the boxes because you might be writing on the wrong side of the page. And it seems that's what the scribe was doing here. So instead of just crossing everything out they put in the boxes, they've just crossed out the headings and let anyone else that comes along and read this, that they put all the left things on the left side of the page and the right things on the right side of the page, which is intuitive to most people, but maybe not to everybody, because we have different stakeholders. In the middle of the page there, you can see they've written some note. It's a bit difficult to decipher, but there is some sort of note in the middle of the page, and there's a mistake at the bottom of the page where they've written over a number. So now it's possibly a 13, a 15, or an 18. But either way, these are issues which really we shouldn't have to deal with. Scribing on paper is cumbersome, and it creates difficulties when we're trying to share this information with others or put it into different locations. So really, the project is about improving this step of one of our processes through the use of software. So projects in software generally take on an agile mindset. I'm not going to talk about waterfall and agile in any detail, really. It's just know that because software is quite easy to rapidly prototype and make new versions, and we generally follow an agile approach, and it's the recommended approach to follow because it is so easy to create a software application for people to test. Obviously, if we're building buildings or railways, it's a bit more difficult to prototype something. So you may follow a more rigid or more structured or linear approach in waterfall, but not always. There are always occasions where you can use that iterative design. But we're going to be talking about agile mindsets here. And another thing we'll do quite often in systems engineering, use some sort of modeling language. Me in particular, my background is in object-oriented software. So I use what's called UML, the Unified Modeling Language, which if you've come across SysML, Systems Modeling Language, that's based on UML. But you may come across other languages like OPM, Object Process Methodology. But really, these are just diagrams to present a concept or an idea or behavior or structure. Both of these diagrams here show behavior. The one on the left is called a use case diagram. You've got two stakeholders, a clinical examiner, a clinical scribe, and they've got two use cases there. The examiner will take a measurement and the scribe will record a measurement. Whereas that one on the right-hand side is about a process of inputting measurements. You input measurement. Is there another one? Yep, do it again, and you iterate until there are no more measurements. So they're just visual representations of things that we may need to record in software. And it just makes it a bit more succinct rather than having just a big block of text. And I'll be using a couple of those on the next few slides. So what processes do we go through in software engineering when thinking about systems engineering? As I said, it's iterative. So all of these things, apart from probably the mission analysis or business analysis, we will iterate on. Hopefully you don't keep iterating on your mission analysis, because that means you've probably got some sort of scope creep and your objectives are changing all the time. But everything else, stakeholder needs and requirements, we can iterate and improve on those constantly. software requirements, which are also, based on those stakeholder requirements, we can iterate and improve on those constantly. And as I said, this is a case study of a live project. So where are we at the moment? Well, we're at the implementation process for our first iteration of the prototype. And I'll show you that at the end. So here's a sample of some requirements. So that first step, stakeholder needs and requirements. Stakeholders say to me, or they don't put it in this language, this is how I've written it down. This is called functional requirement syntax. So you kind of have an object, an actor, some sort of objective, and maybe some conditions. You can also use things like user stories if you're more familiar with that. But I generally use functional requirement syntax. And what it does, it helps you to identify who those stakeholders are, what roles they have, and that will allow us to plan how we're going to address or not address their requirements. It'll also help us to identify, are there any enabling works that need to happen as well? So if some of the stakeholder requirements interact with things outside of our direct control, then we're obviously going to have to include other people and identify how we're going to address those. I've color coded these slightly just for today based on their risk assessment. So we can see, we're talking about software, and quite often one of the requirements of software in a clinical environment is people want things to be automatically calculated or some sort of indicator displayed on the screen. So that yellow requirement in the middle, if we focus on that for a second, it says, when a measurement is entered, the software shall show a warning asking the scribe to check the value if the measurement is 2 standard deviations outside of the normal range. So maybe you've typed something incorrectly, or maybe it's a valid measurement, but one of the requirements was that people want the software to say, please check this value you just entered because it's outside of our normal ranges. And that orange requirement we got in the top left there, the system should automatically calculate the result of a complex measurement and display the result on the screen. This has a higher risk rating because it's got some regulatory impact, which we're going to have to consider. It's not going to change the software development lifecycle because we're using systems engineering, but it may have some additional requirements in the products that we have to produce as a result of that. Once you've got your stakeholder needs and requirements, it's often, or it definitely is, a good idea to look at those system or the software requirements. So based on your stakeholders' needs, you can then start to figure out what the software needs to do. And again, these are based on things that the user has already said. So the system, that red one in the middle, that system shall display the calculation used to calculate complex values so that the result can be verified by a user. The reason that's there is when thinking of software as a medical device, if the calculation is easily verifiable, so maybe it's just a simple addition or subtraction, then you don't have to go down the full regulatory route for this. You should still, develop it within best practices, but it wouldn't be considered software as a medical device. However, we don't say here how complex those calculations are. So there may be things in there which, are outside the bounds of simply being able to simply verify them. So it's not a simple addition. Maybe it's got a square root or something like that in it. Another thing that we've got here, so if we take a look at that orange one in the top left, the system shall allow different types of measurement values to be used based on the measurement's definition. Now, the reason this requirement came about in the discussion is if you measure something like ankle dorsiflexion, you don't want to record it in using different units every time. You don't want to be using a different scale, different terminologies. So when you say, I'm going to measure ankle dorsiflexion, you're going to measure it at the same time. Or you're going to record it the same way every time. And what do system and software requirements and stakeholder requirements lead us to do? It lets us to think about that whole picture then. So the architecture, as we call it in software, it allows us to define the architecture of the system. So thinking of those, some of those requirements, we've got the units of the clinical measurement. We talk about clinical measurement. And that orange one over there, we talk about complex measurement. So as you can see, this is just 3 requirements, but obviously there are many more, have allowed me as the architect to think of what sort of objects or classes are we going to see in our system. Because remember, software holds information in memory whilst you're using the program. So it needs to have a way of representing that information when you write the software. And the way of figuring these out really is looking at those system requirements and developing those so that you can architect something. And architect definition is quite high level. So if you look, there's no detail in these. And that brings us on to that next step, that design definition. So as you can see, it's a very similar diagram, but there's been a slight change. The objects now have attributes in them. So if we put up 2 requirements again, you can see the objects are underlined and the attribute in that one requirement is in bold. And that allows us to add detail to or come up with our actual design or a design definition for our software. And as I said earlier, this is just one small part of the software. Obviously, there's a user interface, there's the processes that go around it, there's the change management that needs to come in when you're actually going to deploy the software. I'm just focusing on one particular area just to demonstrate how we use systems engineering to break down a process into its constituent parts so it makes it easier to develop it and manage it in the future. And we'll do this, as I said, iteratively. So on the left-hand side of this diagram here, we have that normal range that wasn't included in the architecture definition, but it's here in the design definition because these diagrams iterate and improve over time. And the final diagram, just going to throw this up here, is a wireframe. A wireframe diagram is just a way of representing the user interface to show stakeholders, say, is this the sort of thing you're thinking of? And it allows us then to, validate that we're developing the thing that people have asked for. Before we actually go to that implementation, though, we do something called system analysis. I don't really have a picture to demonstrate that, and I didn't want to write hundreds of words. Really, what system analysis is, is you will define how, as Helen and John were saying earlier, what does good look like? So your system analysis will define your measures for identifying whether you've met the requirements of the system and the users. And one thing to note is, yes, you need to meet all your regulatory requirements. Yes, you should be following best practice. But I've not got an academic quote, but one of my favorite YouTubers often says, don't let perfect be the enemy of good. So when you're designing a system, it needs to do everything that it, must do. But don't spend more time than you need to making it perfect when it's good enough. So what does good look like? Because time is valuable for us. So yeah, that system analysis allows us to identify that, allows us to pick the correct design, because as I mentioned earlier, we have multiple designs, multiple options, and that will allow us then to actually go to that implementation stage once we've picked our design. So it's really about breaking down that problem as always. There are lots of other steps after this, which I'm not going to go into, because as I said earlier, we're still at the implementation phase. But if you're integrating into other systems, you'll be doing an integration. You'll need to verify that you've built the right thing, but have you built it correctly, etc. And you must think about how you're going to maintain this software and dispose of it if it does have a disposal in the future. It's not just about going straight in and writing software. So just to conclude, really, hopefully I went through that in high enough level detail not to turn everybody off the subject of software engineering, but enough detail that you can see how systems engineering can be applied to software. So really, one thing to say is you could jump into a software project without doing any of this. If you get everything right first time, the software works perfectly in every situation. The software will never need to be changed, and there will never be any questions about something was designed the way it was. Then doing all this doesn't add much value, but I've never seen a piece of software that is perfect first time and works in every situation that people want it to. So hopefully I've convinced you why systems engineering is a useful and value-added process in software engineering. Thank you.
Fantastic. Thank you, Adam. I think that was really refreshing to see how a sort of very systems engineering approach can actually be applied to something very clinical, such as a physical exam. So it's really at that sort of component process level that it can still be relevant. And actually, if you do it properly, you're going to get a lot more out of it in the long run, as you're saying, rather than just going straight into it and trying to fix the problem without actually truly acknowledging what the problem is. We've had a couple questions through. Firstly, did you come across any reluctance to this change? So, for instance, in our gate labs, staff would point blank refuse to adopt a digital system in favour of putting the pen down. If so, did you or are you dealing with this?
Well, thankfully, no. But one of the things that I would do at the very start, so when we're talking about that mission analysis or business analysis, is identify really whether this is something that people want. So within that business analysis, some of the things that you will be thinking about is identifying some of the problems that exist already. So if there's not a problem with the existing written documentation, then why would you develop a software to do that? If there's no opportunities for improvement by doing this, so you're not going to improve the overall process, or you're not going to improve the quality of the service that you provide, or if there's no opportunities, then why would you do this? And that's why it's important to do that mission analysis right at the start, or that business analysis, whatever you want to call it. It's really identifying the scope, the opportunities, the problem space, and then evaluating whether this is something that is required. The things I've talked about today, they sound like they're a lot of work, but actually a lot of these things happen simultaneously or around, within a short time space. So and each of those steps is, what is the need, what are the risks, and how do we manage those appropriately.
That's it. And I suppose, as you say, if there's no problem in the first place, actually your time might be better spent on focusing on what does good look like elsewhere.
Yeah.
So it's kind of second follow-up question: did you, or I suppose, could you build in any adaptability? And if so, how did or would you capture this, as different user interfaces may work better for different staff members, or sometimes those who may do different measurements in the clinical exam dependent on the referral question? So I suppose you're looking at kind of going outside what would be on that sort of generic form, I guess.
Yeah, that's right. So it's not one of the requirements, but if it was a requirement to have that adaptability, then it is something that you could design for. Obviously, your system requirements are based on your stakeholder or user requirements. And so if nobody is mentioned during your brainstorming or your workshops, however you're managing it, that it would be great to have some adaptability, then it's not something that you're going to consider as the architect or designer of the system. But yes, if it was a requirement, you could write that in quite easily. And that's the benefit of using an agile approach to software projects, is that you can iterate on your design and you can iterate on your implementation to improve the functionality, but also the safety of the system as well. Because if it's a requirement that people need to use different units, there's probably a reason for that rather than just personal preference. So you're increasing the safety of the system as well.
Yeah, as I say, they would probably be in your requirements at the start, hopefully, anyway, unless they weren't mentioned. Fab. Thank you very much for that, Adam. That was really insightful. Again, great practical application, I think, in a clinical service, actually. Okay, so we'll move on to our second case study. I think, Victoria, if you're ready. The second one is by Dr. Victoria Kidgel. I hope I've said that correctly. Victoria is the lead clinical scientist of the Medical Device Management Group at Sheffield Teaching Hospitals. And Victoria will be presenting a case study on root cause analysis in medical device procurement. So if you're ready, Victoria, I'll hand it over to you. not sure if we've got Victoria there. We'll give her a few minutes, I suppose. Hold on a sec. If everyone wants to go and grab a cup of tea or a comfort break, and we'll try and get Victoria back on the line.
Hi, sorry about that. My connection crashed.
Not a problem.
I'm back again.
Technical hiccups, as always, I think, is the it was going so smoothly. We've got you, which is the main thing. Brilliant.
Yeah. Okay, so I'm gonna go straight into my presentation, if that's okay.
Sure, not a problem.
Okay, I'm just going to find it now. Okay, so I'm going to talk about medical device procurement and a root cause analysis project that I've done. So, like John said, I'm Dr. Victoria Kidgell. I'm the lead clinical scientist in the medical device management group in clinical engineering at Sheffield Teaching Hospitals. And I've been doing this role for just over a year now. And when I started in the role, there'd been several procurement cases that had taken an inordinate amount of time. So the head of clinical engineering tasked me with doing a root cause analysis of some of them to see what was going wrong and to see if we could streamline the process and make things better for the future. So I'm just going to give a little bit of a background on different root cause analysis techniques. I don't know what all of your backgrounds are and how familiar you are with them. Then I'm going to talk about the problem that I investigated, the process that I used, the results, and then some proposed solutions. So root cause analysis is a systematic analysis to uncover the fundamental causes of an incident, failure, or a problem. So it's trying to really unpick those root causes and not just look at addressing the symptoms. So the steps for undertaking a root cause analysis is you want to start off with defining the problem, then collecting the data, identifying those causal factors, and then from that identifying the root causes, which will allow you to find corrective and preventative solutions. And then from that you want to create actionable strategies and then implement those solutions. And a really important stage is to monitor that solution and confirm it works, and then make some steps to address it if it's not working, to put in some different actions. Okay, so I'm just going to quickly whiz through a few different root cause analysis techniques that I investigated when I started this project, just to try and see which one would work best, because they're not all suitable for all scenarios. So the first one we've heard mentioned a few times today is the Six Sigma technique, and that's used a lot by people to improve business processes by reducing defects and errors, minimising variation, and increasing quality and efficiency. So the focus is always on the customer or the end user, and that improvement is a continuous process. You want to reduce process variation and eliminate any waste to enhance your outcomes. And leadership development is crucial for continued success. And finally, you want to define and control all your processes. Another one that you can use is Pareto charts, and they're often used to identify areas to focus on, first in the process improvement by assessing competing problems and measuring the impact of fixing them. They use the 80-20 rule, where 80% of the benefit comes from 20% of the work. So it identifies the problem areas and tasks that will have the biggest payoff, and they show the ordered frequency counts of variables for the different levels of a categorical or nominal variable. So you want to identify and list your problems, and then identify the root cause of each problem, and then score the problems and score them by importance. You can group problems together and then add up the scores for each group. So that'll tell you where you should really focus your attention for the biggest impact. Another one is failure mode and effect analysis. This was developed in the 1950s and is a structured approach to discovering potential failures that may exist. And the failure modes are the ways in which the process can fail, and the effects are the way that these failures lead to waste, defects, or harmful outcomes. And they can broadly be categorized into design, failure mode and effect analysis, and processes. And the process FMEA discovers failure that impacts product quality, reduced reliability, customer dissatisfaction, safety, or environmental hazards. And they derive from things like human factors, the methods followed, the materials used, machines utilised, etc. Another one which I was going to use for this project was the Ishikawa fishbone analysis. And this is a causal diagram that shows potential causes of a specific event. And it's a really good visualization tool for categorizing the potential causes of a problem. And this is just an example, so don't worry about not being able to read it. But the common causes are product design and quality defect prevention to identify the potential factors causing an overall effect. So what you want to do is identify the problem and then identify the major factors that come off it on these big spines. And then you identify possible factors for each of those main categories that may contribute to the problem. And those are the little sticks that come off the main spines. And then you want to investigate those underlying factors further using different robust identification tools. You can also use a fault tree analysis, which again is a graphical tool to explore the causes of system level failures, and it's widely used to determine possible causes of an unexpected event, which is called the top event. This one is a top-down approach as opposed to the bottom-up approach of FMEA. And again, it allows a visual investigation of the causal factors to look for those root causes and focuses on all possible system failures of the undesired top event. And then the final one that I looked into was the 5 whys. And so stubborn or recurrent problems, they're often symptoms of deeper issues. So if you find that you've got a problem and no matter what you try, it just keeps happening or you just can't solve it, it's probably because you're actually looking at the symptom rather than the underlying cause. So this was developed in the 1930s by Sakichi Toyoda, the Japanese industrialist, inventor and founder of Toyota. Became popular in the 1970s and it's still used today to solve problems. And it uses countermeasures rather than solutions. So a countermeasure is an action or set of actions that seek to prevent the problem from arising again, whereas a solution may just seek to deal with the symptom. So countermeasures are more robust and will more likely prevent the problem from reoccurring. And you need to take those countermeasures at every level of the 5 whys. So this helps to build more robust processes and systems, resulting in fewer problems happening in the first place. And you'll also find that what at first glance appears to be a technical problem often transpires to be a human or process problem at its root. So a good thing to do is to organise an initial meeting and define your problem statement, and then ask that first why, and then keep asking why 4 more times. And at each level, determine your countermeasures and assign responsibilities for those. And you also need to make sure that you're monitoring your progress throughout, so that you're not just sort of banging your head against a brick wall, you're actually doing something that is making a difference. So the particular problem that I looked for in this case study, we had several procurement projects, like I said, that went a bit awry, took a very long time, and I focused on these 2. So we had an image intensifier procurement process and one for ultrasound. So to start with, for the image intensifiers, this was a procurement process for the planned replacement of 11 image intensifiers in the trust. The procurement process took over 2 years to complete, but actually is still not complete. The original bid was submitted to the Medical Device Management Group in September 2020, and in April 2021, a 4-year planned replacement programme was signed off, and the order was placed in November 2022. We have the majority of the devices now on site and in use, but we still have one final device left to be delivered. That's now been pushed into 24-25 financial year just due to budget cuts and other bids taking priority. But at the time when it was submitted, it was ranked 2 out of 5 in priority for replacement in 21-22. And then the ultrasound plan replacement. So this was a combined procurement of ultrasound machines for our general radiology department and also our obstetrics and gynecology department. The replacement programme was combined due to some similarities in the requirements, which was thought at the time would make the specification and the procurement process slicker and easier, but actually led to a lot of issues later down the line due to the difference in requirements and specification. There was also delays in the equipment trials and the scoring due to availability of clinicians. There were delays in other areas, which I'll come on to a bit later on. So this one was originally agreed in April 2021 and is still incomplete. The procurement is still ongoing, but we do finally have the winning bidder confirmed, which has been confirmed this month. So we are hoping to get them on site in the very near future. So the process that I used to undertake this root cause analysis was I started off conducting interviews with all the relevant parties. So that included people from finance, procurement, clinical engineering, and different clinical teams. So I want to point out that these procurement processes started a long time before I joined the medical device management group. So at the time I was working in a clinical role, so had nothing to do with any of this. So it lent me a degree of impartiality in the process. I didn't have any investment in it, so it made conducting these interviews a bit easier. I then created a detailed timeline, and for that I used data from our medical device management group tracker. So we keep a tracker for all our bids, which month by month we have a catch-up meeting and we discuss where the procurement process is for each bid. So I use details from that. I also use the MDMG meeting minutes and also information from the interviews that I conducted. From all that data, I created a high-level process chart and I colour-coded this, and I put in the details month by month of what stage the bid was at, and then I colour-coded it to show who had responsibility. So you could see at a glance where the bid was and at what stage it was. And I then created a Gantt chart of the timeline of the bid, and I grouped that into different phases, so you could see how long each phase of the project took, and it just gave a really good visual representation of each part of the process, and I'll show you an example of that in a moment. And then I also created a process flowchart, and that just showed the processes, the different processes that were involved in the procurement project. And it also helped to identify where any delays were and if there were any sort of loops, feedback loops that shouldn't have been there that held up the process. So here's an example of one of the Gantt charts I created. Don't worry about the words. I know they're really tiny and you won't be able to read them. But the point is that you can see sort of how long each process took. So along the top of the chart, it's calendar months. The yellow shows when the bid was submitted and when it was finally approved. The blue shows how long the statement of requirements and specification took. The pink shows the value for money stage, and for anyone who's not in the NHS or not to do with procurement, that's the finance side of things. So they're putting their pricing schedule out, getting any clarifications on pricing from the suppliers. The sort of slightly purpley blue boxes are the equipment trials that were taken. The green is for the quality scoring, so that's scoring from the clinicians. So the clinicians who are involved in the equipment trials have to score all of the different devices, and we also get scores from clinical engineering on things like maintenance and contracts and things. And you can see then right at the end, the order was placed in November 2022, and the first devices were delivered then as well. So you can see that some areas during this process took a really long time. So that's what we were trying to investigate, why that happened. So this is the process flowchart that I created. And again, it's color coded just to show the different areas. So this top line here, above the dotted line, that's a sort of high level process flowchart. So we go from the approval to the statement of requirements and specification, excuse me, to value for money, equipment trials, quality scoring, and then back to value for money, and then the process completion. And then underneath, we've got all the steps that happened within those different stages. And these red dotted lines show areas where we had feedback loops, where we were having to get constant clarifications, the specification was being updated, and that really slowed the process down. Okay, so the results from this was, using the 5 whys technique, we identified 6 key problem areas. So one of them was staffing. So it's a real problem, as you'll probably find right throughout the NHS and other organisations, staffing levels and availability. So it's a particular problem in the NHS that we are overworked, understaffed, and there is no dedicated or protected time to spend on the procurement processes. The specification, we had a lot of problems with that. We had a lack of technical knowledge and lack of technical expertise in the project team, so in the clinical team, and then a lack of clinical knowledge in the procurement and finance team. So there were quite a lot of gaps and lack of understanding between the two sides of the team. Another problem we had was that the equipment brought to trials was often slightly different to the equipment that was in the specification or was in the quote. So suppliers sometimes brought along additional equipment, which then the clinicians really liked, but obviously it wasn't in the quote or in the specification. And then other suppliers hadn't brought those pieces of equipment, so we had to keep going back and forth to get clarifications on that. The quality scoring, again, multiple clarifications were required, and also the clinicians took a really long time to return their scoring sheets in some cases. Finance was another key area. We found that there were changes made to the pricing schedule. There were multiple clarifications, inconsistent quote formats sent back from the suppliers, and discrepancies in what was included from different suppliers. And also the NHS supply chain, we found that they were giving conflicting advice regarding what documentation was allowed or required. There was often incorrect or missing information not being supplied to the procurement team from the suppliers, and often a lack of cooperation or engagement. They had quite a high staff turnover, which made it difficult as well. So then we came up with some proposed solutions for going forward. So one key thing which a lot of clinical teams have said they really want is a procurement project process plan. So when they start these procurement projects, they want to have an idea of what's involved, what are the timescales, what are they committing to. Excuse me. We also propose using standard documentation, so always using the NHS supply chain standard documentation, trying not to deviate from that so that it sort of minimises the workload that we have to do. Ensuring timely progression of bids. That's quite a broad title, but actually involves a lot of work. So I'm currently working with the ops directors and service leads throughout the trust to try and work with them earlier in their business planning stage to ensure that they are prioritising equipment for replacement early on, getting the bids submitted early on, and not waiting for equipment to break down before they want to replace it, because as you've seen, some of these procurement processes do take a long time. Sometimes suppliers have long lead times. And then also ensuring that if bids are progressed earlier in the financial year, it means that staff in procurement and finance have more time available as well. Ensuring that there's a detailed and accurate specification, making sure that it really captures the service needs, not their wants, but their needs, so that the equipment does meet their requirements. Ensuring that the teams have dedicated time to work on bid progression. That's a really key point, because without the time, clinicians are trying to fit this in around their other clinical workload, which, as we all know, is incredibly high, and they don't have time for it. So we need to ensure that they've got dedicated time. And like I spoke about before, engaging the clinical teams earlier in the process. Making sure that we don't make any changes to published documents once they've been published for tender. So that will be the specification and pricing schedule. Also ensuring that advice is sought from experts as required. So, for example, getting advice from clinical engineering on technical aspects. And ensuring that clarifications are received in a timely manner from the suppliers. So that might mean just a little bit more work on our side from the procurement and finance teams. So just in summary, the use of root cause analysis techniques here ensured that a robust process was undertaken, and it meant that we resulted in countermeasures to prevent these problems reoccurring. So we have made changes to our procurement process now, and things do seem to be improving. Like I said, we're constantly monitoring it. We're constantly making new changes as we find that things need further improvements, but we definitely feel like we're moving in the right direction. Okay. Sorry. Okay, so thank you for listening. If anyone does have any questions or wants to get in contact, you've got my email there. Thank you very much. I will stop sharing.
Okay, thank you very much, Victoria. That was really, again, another brilliant application. It's really that everyone can see in healthcare. I think it's really important. I think I'm sure everyone who works in healthcare has had their issues with procurement at some point within their careers, whether that's directly or indirectly. We've had a couple questions come through. So firstly, we'll start with how have you disseminated the learning for other projects in the future?
So the findings of this were written up in reports which were presented to our capital investment team. So that's been disseminated throughout the sort of higher management groups and the ops directors. And so I work in the minor medical group, so anything between 5,000 and 150,000. But now the major medical group are going to be undertaking their own root cause analysis and looking at changing their procurement processes as well for their higher value capital items as well.
It's good to hear people are taking on board some of the learnings anyway. I think
yes, yeah,
to sort of not being stuck in silos, which we typically are in sort of clinical engineering services, aren't we? So definitely trying to share the message between I
think that's been one of the big things actually was just getting better communication and just working with the different teams and working with them earlier on as well. And I think for a lot of clinical teams, the procurement process has felt a bit of a black hole. So just giving them better understanding has really helped as well.
Yeah, it's always good feedback, isn't it? I think.
Yeah.
So what change do you feel has had the biggest impact?
The biggest impact. There's been a few, but I think the biggest one actually has been working with the clinical teams and the ops directors. We've had a lot of feedback from them that they find it really useful. They've got a lot better understanding of the procurement process and the requirements and why certain things have to be done and in certain orders, because I think there was a lot of frustration that they felt that they submitted a bid and then it just sort of disappeared, and then months and possibly years later they may end up with a bit of equipment. So I think just that communication actually has been one of the biggest impacts for us.
Yeah, definitely. I think that's something we see in our services anyway, which are very patient focused, is it can be so long between, you know, the clinician seeing them and them getting their proposed solution, that actually along the way people have no idea what's going on, and it's that sort of lack of communication, isn't it, that really winds people up, I think, and that can lead to complaints, definitely, in our service.
Absolutely, yeah.
So I noticed you did use the 5 whys approach. Was there any reason why you went for that one over some of the other traditional methods? You discussed the Ishikawa and the other techniques.
Yeah, it just seemed to work quite well for us. We did start off looking at some of the other ones and using some of the other ones, but that one just seemed to fit quite nicely with the project, and gave us quite a lot of useful sort of solutions to put in place.
Great. And you didn't find that there was any difficulty in applying concepts that were perhaps made for different industries and trying to apply them to healthcare?
Yes, so sometimes, yeah, I think some things are quite targeted more to sort of industrial applications, business applications. So it's just sort of working out how you can apply that to a healthcare setting instead. So yeah, it does require sometimes a little bit of lateral thinking, but yeah, we got there.
Got there in the end.
Yeah.
I think we have one final question. So did you use any, I see you noticed using the Gantt charts and the process mapping. Did you use any software to kind of come up with these, or was there any kind of website you used to help form particularly the process maps?
No, I didn't actually, just because I was quite new to the role. So for this particular task, we didn't, so like the Gantt charts was sort of done in Excel. It was a bit old school, to be honest, but there is a lot of software out there, and we've got some software for doing like the process maps and things now. So I think going forwards, we'll probably use that just to make it a bit slicker and a bit faster. But for this one, yeah, we didn't.
Great. Right. At least you can still say there's tools you've used that, you know, it doesn't have to be some fancy software that maybe people don't always have access to.
Yeah.
Great. Well, thank you very much for your time, Victoria. Again, it was really good to see a practical application in healthcare, particularly in a different type of service, which Adam presented earlier. So yeah, thank you very much.
Thank you.
We are just waiting on our last speaker, Andy. I think he's had some technical issues joining, so I think we'll have a 5-minute break, and if everyone could reconvene again at 3:57, and we'll see if he's been able to join us. If he hasn't, we'll call it a day. But as I say, we'll give him 5 minutes to try and connect. So go and grab yourselves a cup of tea, or have a comfort break, and we'll see you again a few minutes to 4. Okay, hi everyone. I think we are going to have to skip our last presenter, unfortunately. I think he's having some real big technical difficulties trying to log on to the workcast. So hopefully if anyone has any final questions, if you want to pop them in the chat now for any of our speakers. Again, I think a big thank you to all our speakers. Our key speakers are brilliant in terms of giving us a grounding of that systems engineering theory. And then we followed that with a couple great case studies on some practical applications in clinical services. Just a reminder that the webinar has been recorded. Should you wish to watch it back, or if you have any colleagues who you think it would be relevant to pass it across to them, that would be great as well. Okay, thank you very much, everyone, for your time. We'll see you later.